So students, let's discuss some of the important points that are likely to come in the INI-CET paper. Capgras syndrome, Frigoli syndrome is always a favorite of INI-CET examiners. We have to remember that when the question says that a close person got replaced by a stranger, it is Capgras syndrome. Close person got replaced by a stranger. And when we say that close person is disguising as a stranger, this is Frigoli syndrome. Close person is disguising as a stranger or multiple strangers, that is Frigoli syndrome. Antipsychotics with minimal weight gain, important point for your INI-CET exam. We have to remember 3 A's: aripiprazole, acinapine, and amisulpride. We have cariprazine, we have ziprasidone, and we have haloperidol. Likely to be asked in the exams. Okay? TCA toxicity, they will present you a case, they will give you a case which will have anticholinergic symptoms like dry mouth and increased temperature, not sweating, right? They will also add some CVS and CNS symptoms. The chest pain is there. There is decreased respiratory rate. There may be convulsions, and they will probably throw the ECG findings. We know that prolonged QRS interval is the most important ECG finding. If the QRS interval is more than 100 millisecond, we have to initiate the treatment in the form of sodium bicarbonate. One of the favorite questions likely to be asked in the exams. Antidepressant with minimal sexual side effect, another important question. Bupropion is one, mirtazapine is another, and agomelatine is the third one. Remember, likely to be asked in the exam. In the OCD treatment, remember that the first line treatment would be your medical treatment would be your SSRIs or clomipramine. If you have to pick one, you will pick SSRIs. Often the patient do not respond completely to SSRIs or clomipramine, then you have to augment. And for augmentation, one of the best drugs is a antipsychotic, one of the antipsychotics. We use risperidone and aripiprazole more. One of the drugs, newer drugs, which is being increasingly used, might be asked for OCD, not a first line. Third line maybe is memantine, NMDA receptor antagonist, memantine. If they are talk about the therapy, then it is the best therapy is, or the therapy of choice is exposure and response prevention. For postpartum depression, 2 drugs have been approved. One is zuranolone, the other is brexanolone. Both of them are allosteric modulator of GABA A receptors. This can be asked in the exams.
Hello friends, myself Dr. Shrikant Verma, Faculty of Anatomy at Cerebellum Academy, author and international educator. So here I am going to tell you what are the must-do anatomy topics for this INI-CET November 2025. These all are based on the basis of the micro-analysis of the recent papers. So according to the recent paper, you will see the joint and the parts of the bone. They are asked in the INI-CET exam. Any one joint, definitely it is going to ask directly or indirectly or in relation with the other subjects like the orthopedics or radiology. Yes, hybrid muscle is always one of the favorite topic. They can ask this one on the basis of the cadaveric images. Glands, so thyroid gland, parotid gland, submandibular gland, and also the adrenal gland. Yes, definitely one question directly or indirectly with relation to the surgery, or you can say the ENT, they can ask. Cranial nerves and the skull foramen. Yes, it is always favorite question. They can ask any cranial nerve on the basis of the clinical pattern. They can ask any particular skull and the foramen and what are the structures which are passing. And definitely the pterion. It is very, very favorite question for our INI-CET exam pattern. Yes, any muscle can be asked, but in INI-CET, the muscles of mastication, they are favorite topic. Okay, so you have to prepare the cadaveric images also, and also you have to know all the facts related to the pharyngeal apparatus in relation to the muscles of the mastication. Yes, laryngeal nerves, This topic is related with the anatomy as well as ENT, as well as you can say the surgery and the medicine. So laryngeal nerves are recently the important topics. Yes, definitely the brain section in correlation with the radiology, CT and the MRI also you have to prepare. Especially in the brain section, you have to focus for the basal nuclei and the Parkinson clinical correlation may be asked. Then cerebellum, one question from the cerebellum, either from the anatomy or the physiology or the pharmacology. Yes, the cerebral toxic drug like the lithium. And also you have to correlate with the medicine. Cerebellum is important, especially you have to look for the histology of the cerebellum, the molecular Purkinje layer and the granular layer. Now the nerves of the upper limb and the lower limb along with the different test in the clinical is very important nowadays. In the upper limb, yes, definitely the median nerve, radial nerve, ulnar nerve, the musculocutaneous nerve, these are important. Nowadays they are asking the anterior introosseous nerve and the posterior introosseous nerve with their test with orthopedics integration. Yes, in the similar way, lower limb nerves and their tests are important, especially in the lower limb, the sciatic nerve, the common peroneal nerve, the deep peroneal nerve, the superficial peroneal nerve. These are important. Also, you have to know about the femoral nerve and the obturator nerve. Lateral cutis of the thigh supplied by the meralgia paresthesia, supplied by the it is lateral cutis of the thigh, it is related with the meralgia paresthesia. Also the lumbosacral plexus they are asked. Okay, now the gluteal region, it is very favorite topic of the INI-CET exam. Gluteal region, gluteus medius, gluteus minimus, gluteus maximus, their cadaveric images or any kind of the osteology integration they are asked. Inguinal canal and inguinal hernia, it is very important. Yes, you have to also focus for the surgery aspect. Now in the our abdomen part, the peritoneum, yes, the Pringles maneuver, the different spaces, the peritoneal ligament, like the falciform ligament, splenorenal, or you can say the linorenal ligament. Yes, also the gastrosplenic ligament. Okay, Pringles maneuver you have to look. So peritoneum with relation to the clinical, like the peritonitis, very important. Now the diaphragm. During the class, I taught you total 8 diaphragms in the body, among which the thoracoabdominal diaphragm, the pelvic diaphragm. Pelvic diaphragm was a very favorite question for the INI-CET. Also, the urogenital diaphragm. You can say the perineal membrane with the superficial and deep perineal pouch. It is important topic. Pharyngeal apparatus in embryology part. The pharyngeal apparatus, especially the pharyngeal arch artery, you have to look. Also, you have to see the pharyngeal arch, pharyngeal cleft, and the pharyngeal. You have to see the pharyngeal arch, pharyngeal cleft, pharyngeal pouch. Also, I taught you the pharyngeal membranes. Now, in the general embryology, suddenly in previous few papers, they ask about the our sperm, spermatogenesis, oogenesis, the neural crest cells, and the germ cell layers. They are very important. Okay, so in histology part, yes, you have to look for the epithelium and the glands. Glands, you can say the merocrine, the holocrine, the ecrine. Right now, they are asking the paracrine gland also. Yes, and it is one usual pattern in your anatomy: one artery, one vein, one nerve, one bone, and one joint is usually asked. Okay, so this is the list for the all the important topics of the anatomy, especially for the INI-CET. And remember, you have to focus in integrated way. Maybe they are not asking the question of the anatomy directly, but indirectly they will give the clinical scenario or the clinical any kind of the images, and then they will ask the anatomy. सो रिमेंबर, रणभूमि में खेलने से पहले मनोभूमि में खेला जाता है. एंड रिमेंबर, एवरीवन हैज अ प्लान, but they change it after the first punch on the mouth. Okay, so don't change your plan. All the best. God bless you all. You are going to crack the exam tomorrow.
Hello everyone, myself Dr. Pooja, and today we are going to discuss the INI-CET Physiology pre-exam session. So first question, which of the following physiological process is not correctly paired with the structures, right? So electrical transmission for the gap junctions, that is true, right? Because electrical transmission happens in the via the gap junctions, connects in, connects on. Negative feedback inhibition, Renshaw cell. What is the Renshaw cell? It is used for the feedback inhibition or recurrent inhibition. You can see alpha motor neuron, while going towards the muscle, gives the collateral to the inhibitory interneuron. As the name suggests, it's an inhibitory interneuron. But look where it is going. It is going on the alpha motor neuron itself. Hence, it is a feedback. It is coming back towards the alpha motor neuron who stimulated it and inhibits the alpha motor neuron itself. So that is true. It's a negative feedback inhibition. Synaptic vesicle docking and fusion. Docking means the snare protein, the V snare and T snare, they attach with each other and the vesicle fuse in the membrane of the axon terminal. That happens presynaptically. That is also true. End plate potential, muscarinic cholinergic receptor. Mind you, in the EC coupling, excitation contraction coupling, we have nicotinic type of receptors, acetylcholine receptors. was not the muscarinic type. So this is wrong, right? Action potential generation can happen in the initial segment, can happen in the nodes of Ranvier, depending on whether it's a motor or sensory neuron respectively, right? So answer over here is option 4, which is incorrect. Let's move on to the next question. Heart rate is given in this question, and one graph is given. What they're asking over here, it's a left ventricular pressure volume loop, basically, right? What they're asking is cardiac output. So how do you calculate cardiac output? If you know the heart rate, see the BP there is no role in this, right? First of all, they're asking about cardiac output, and what they're asking is second heart sound. Cardiac output, formula is stroke volume into heart rate. We already know the heart rate, we have to calculate the stroke volume. How can I calculate the stroke volume? The maximum volume is going to be your EDV and the minimum is going to be your ESV. I told you that, right? So 150 minus 50, that is EDV minus ESV is going to be your stroke volume. That is going to be stroke volume is equal to 100, right? 100 ml. Why? Because EDV minus ESV. So 100 into 70, that is going to be 7,000 ml, or you can say 7 liters, right? So we got the cardiac output. So 2 options are already out. Now, I told you where the second, when the second heart sound comes, when the cellular valve closes. Cellular valve in the left heart is going to be your aortic valve. And we have the mnemonic that is MAM Coco, right? I told you MAM Coco, C-O-C-O. Close, open, close, open. So the aortic valve closure is going to be the second heart sound. Hence the answer over here is option D, which gives it correctly. Hemoglobin dissociation curve shifts towards the right tag, and remember the mnemonic, right? So CO poisoning mate is going to shift towards the left-hand side, not a right-hand side. It shifts towards the left in the raise in temperature. No, tag mate T was the temperature, rise in the temperature causes right shift. That is also wrong. Left shift with the rise in the pH, that's true. Alkali causes left shift, acid causes right shift. So that is true. To the right with the decrease in 2,3 ppg. No, increase in the 2,3 ppg. You have to increase the right tag, not decrease it. So answer over here is option C. Let's move on to the next thing, that is the graph is given that the hypothalamic set point is changing, right, due to bacterial infection or whatever it is, right? So on the graph shown, this corresponds to the transition from V to X, right? So now there is a new higher baseline for the temperature is shown, right? V to X, right? Which of the following physiological responses is most likely to occur at W? Now, please remember what is happening is this blue line is 1 and this pink line is second. Let's say, what is the 1? Hypothalamic set point is drastically changing. It is instantly changing, right? And whatever hypothalamus gives the command to the body has to follow it. So at this pink line, the second one, the body is actually enhancing the temperature, right, to meet that set point. Now there is a new higher set point, so but the body will start shivering and vasoconstriction, heat conservation, so as to increase the body temperature. So please remember, sweating will cause heat loss, so it will not increase the body's temperature. It is required to decrease the body temperature. Blood flow to the skin. When you increase the blood flow, of course, it is going to cause the increase in the heat loss, not heat gain, and decrease in the body temperature. Inhibition of thermogenesis again decreases the body temperature. Only the shivering is going to cause increase in the body temperature. Whenever the muscle is going to contract, there will be utilization of ATP and the heat generation. So option B is going to be the answer over here. The patient is shown and we have to identify the posture. Both the things, that is upper limb and lower limb, they are extended. So there's a decerebrate rigidity. So option A and option C is already out. And please remember, in the decerebrate, the red nucleus, that is rubrospinal tract, is also gone. So there is a loss of red nucleus control on the upper hand. And that's why the upper limb is also extended. It is not flexed, right? On the other hand, if you look over here, intact activation, this is going to occur in the decorticate, not decerebrate. So answer over over here is option B. Let's move on to the next, match the pairs, right? So see over here, kind stroke. What is kind stroke? Kind stroke is the cyclic hyperventilation followed by apnea. So one is going to correspond with D. If you even remember this, any one of this, you can solve this question easily. At least you should know that the Kussmaul's breathing is going to be seen in the diabetic ketoacidosis. So second is going to be P. And if you see Biot's breathing, what I told you, Biot's breathing is brainstem damage. Brainstem causes a regulation of respiration. Regulation is gone. Bekar breathing, useless breathing, pathetic breathing, right? So irregular breathing will be seen, and apneustic breathing. Apneustic breathing is going to be because of the damage to the pons, causing prolonged inspiratory spasm, right, or inspiratory pauses. Pons over here means upper pons. Basically, they are talking about the pneumotaxic center, right, midpointine lesion and the vagotomy. So the answer over here is option B. Let's move on to the next question, EGF, that is epidermal growth factor. What they're asking, if you see over here, the proliferation and formation of numerous kidney cysts, what type of drug might be useful in treating this condition? It is because of the epidermal growth factor receptors. So we have to block it, right? So for the blockage of this, we have to give the tyrosine kinase inhibitor. Why tyrosine kinase inhibitor? Because all the growth hormone and insulin acts via these receptors. Isn't it dirty piglet, remember? So that is going to be there. So answer over here is option D. It is not going to act via cyclic AMP. Hence, we cannot give the cyclase stimulator or cyclase inhibitor and neither the phosphatase inhibitor. Right. Let's move on to the next question. Identify the cell. So what you can see over here, this is the Bowman's capsule. This is nothing but the macula densa. These are the glomerular capillaries. And what you can see that there are some small cells over here. These are the extraglomerular mesangial cells, and these are the similar mesangial cells, but they are inside the glomerulus. We call it as intraglomerular mesangial cells. So basically what we have to identify is this, that is extraglomerular mesangial cells, also known as Lassus cell, which is a part of JG apparatus. Hence, the answer over here is Lassus cell. I can mark the mesangial cells if I do not have the Lassus cell in the option. Why? Because I'm not marking the mesangial cells over here because there are intraglomerular as well as extraglomerular mesangial cells. So please remember the better answer over here is going to be Lassus cell. Let's move on to the next question. If the pH of the blood is 7.8. So basically this is of the acidosis and alkalosis question. What I told you that always look at the pH first. pH will tell you whether it is acidosis or alkalosis. It is 7.8, which is much more than the 7.45. So of course it is alkalosis, not acidosis. So two options are already out. PCO2 value normally is 35 to 45 mmHg. Over here the acid is increased. If the acid is increased and the alkalosis is occurring, that means this is compensating. This is going contrast to the pH change, right? I told you whatever is going to contrast to the pH change. So that is going to be your compensatory mechanism, not the system which is actually causing this change, right? And bicarbonate, if you see over here, it is increase 22 to 26 as per the physiology, with 22 to 28 milliequivalent per liter as per the medicine books. It is more than 28. That means the alkali is increased, which is of metabolic system. So this is nothing but metabolic alkalosis with the respiratory compensation. Match the following. Again, match the following. Alpha cells of the pancreas are going to secrete the glucagon with some amount of glycine and pancreastatin, right? Beta cells, we all know it is going to release the insulin. So this is the easiest question I see, right? B cells or delta cells, somatostatin, pancreatic polypeptide are released from the PP cell. That's why they are called as pancreatic polypeptide or PP cells. G cells, on the other hand, is going to, especially in the duodenum, in the pancreas, which is present, or in the stomach also, within gastric release, that is going to be there. So option C is matching all these boxes, right? So that is all from my side. Inhale, exhale, it is well. All of this is the part of the story that you will tell. You are going to do well. All the very best, and thank you.
Hello, my dear friends. Most important topic of biochemistry for upcoming exam are glycogen storage disease, sphingolipidosis, urea cycle defect, in bone anaerobic metabolism, alcohol metabolism, vitamin deficiencies, fatty acid oxidation, lipoprotein metabolism and hyperlipoproteinemia, genetic techniques, microRNA, and epigenetics. To cover these topics, you may go with quick revision videos or mission classes. Best wishes.
Hello everyone. In this video, we will discuss the most important 10 topics that are likely to be asked in INI-CET. So the first one, it is HIV entry inhibitor. So first of all, what happens? Glycoprotein 120, it binds to CD4 receptors on the CD4 cell. The drug inhibiting glycoprotein 120 is fostemsavir. So in Kolkatan language or because in Bengali language, it's a fostem. Fostem, so look like first step. So first step is inhibited by fostemsavir, that is attachment, that is binding to 120. After it bind to CD4, now the drug inhibiting CD4 receptor is ibalizumab. Ibalizumab. So it is saying I bind after IBA. Ibalizumab says I bind after attachment. So second step is inhibited by ibalizumab. Then third thing is we can inhibit the co-receptor which is CCR5, that is inhibited by maraviroc. Maraviroc inhibits the co-receptor. And lastly, we can inhibit the fusion when the drug bind to glycoprotein 41. The name is enfuvirtide. The name says bind to envelope and fusion of virus with the T cell is inhibited. The name says completely. Okay, so this is the first topic. The second one is mechanism of anti-epileptic through GABA. Remember, GABA is stored, then it is released. After that, it is either metabolized by GABA transaminase. So if we inhibit that, GABA level will increase, and the drug inhibiting this is vigabatrin. So again, the name says it is saying GABA transaminase inhibitor, and it causes visual field contraction as a side effect. Second drug, GABA will be reuptake. If we inhibit the reuptake by inhibiting the transporter GAT1, GABA will not go back. It will stay there, produce more action. And the drug inhibiting GAT1 is tiagabin. Again, the name says transport inhibitor of GABA. By inhibiting GAT1, that means GABA transporter 1. Okay. Then third thing, the GABA which is produced, it may act on the chloride channels. So the drugs modulating the chloride channels are barbiturates and benzodiazepines. Okay. So you should be thorough about these. The next topic is cystic fibrosis. So we have cystic fibrosis protein. There is defect in the proteins, the chloride channels. So there are two types of drugs. One are called correctors. Second are called potentiators. Correctors will correct the misfolded protein, whereas potentiators will open the channel. So which are the potentiators? Remember, name of all of them will end with CAFTR. So CAFTR says cystic fibrosis transmembrane protein. Okay, so CAFTR is the common thing. Now potentiator, they will open the channel. So they say it's my duty to open the channel. So it's I means it's my duty. Duty means duty. So Eva CAFTR and Dute Eva CAFTR. Dute Eva CAFTR is a new drug. So Dute Eva CAFTR, and remember deuterium is attached to Dute Eva CAFTR, so it is long acting. It's a longer half-life than Eva CAFTR. Both are potentiator. Then correctors. So correctors say that let the engine vibrate. So let the engine vibrate means L means lumacaftor, T means tizacaftor, engine E means elexacaftor, and vibrate V means benzacaftor. So this is again a new drug. So these are correctors and potentiators. Okay. The next, there are some scales which can be asked in the INI-CET exam. Rumac-Matthew scale, that is for paracetamol overdose. So when to use N-acetylcysteine, this scale is used. Rumac-Matthew nomogram. Hartford nomogram is for aminoglycosides. Naranjo scale is for adverse drug reactions. And Matske scale is for vancomycin. So remember these scales. The next one you all must be knowing about Line-Weaver-Burke plot. How to know which type of enzyme inhibition it is. It's a plot between 1 by S and 1 by substrate and 1 by reaction velocity. So in competitive inhibition, you can remember the lines will cross at y-axis. If the lines cross, C means competition, C means cross. If the lines cross at y-axis, it is competitive. On the other hand, if the lines start from x-axis and they go away, just like your x, they go away, but mere yaar da koi competition nahi, so x da koi competition nahi, so that is non-competitive. Now, if the lines are parallel, it is uncompetitive inhibition. You can see the U, if we draw parallel lines and then meet them, it becomes U. So U means uncompetitive, they are parallel lines. And if the lines are crossing but not on y-axis, anywhere else, the lines are crossing somewhere else, then it is mixed. Okay. So remember these type of inhibitions. Next is different type of effect on blood pressure. Drugs producing different effects on blood pressure. So biphasic response, BP increase also, decrease also, produced by adrenal. Then only increase with the bradycardia, it is produced by noradrenal. Only decrease with increase in heart rate is produced by isoprenaline. Then if we give alpha blocker first and then give adrenaline, then BP only falls, BP do not increase. So normal effect is reversed. So this is known as vasomotor reversal. Now, if the graph keep on decreasing with same dose we are giving, graph keep on decreasing, it is a tachyphylaxis. Tachyphylaxis shown by ephedrine tyramine-like drugs. And lastly, after giving atropine, normally acetylcholine produce bradycardia, decrease in heart rate. But after giving atropine, high dose of acetylcholine is increasing the BP and heart rate. This is called the nicotinic effect of acetylcholine. Okay, so these graphs are also important. The most important anti-diabetic drugs are gliflozins. Gliflozins are SGLT2 inhibitors. So what is important to remember about them? Their name ends with gliflozin, canagliflozin, dapagliflozin, empagliflozin. Plenty of drugs are there. So what is important that they are used in type 2 diabetes mellitus, and they have two special advantages. They are very, very good for heart. They have protective effect on heart. In fact, they are approved in congestive heart failure. They can decrease mortality. Second, they are very good for kidney also. They prevent the progression of kidney disease in diabetes. So these are the two special points. Major side effects you need to remember. One obviously is UTI because glucose goes in urine. But second, very important, if we use them in type 1 diabetes and stop giving insulin, they can lead to euglycemic ketoacidosis. Euglycemic ketoacidosis. Okay. Then adverse effect of anti-HIV drugs are important. Zidovudin, if you are very जिद्दी तो आपकी हड्डी तोड़ देंगे, मैरो सप्रेशन हो जाएगी, बोन मैरो सप्रेशन. अबाकाविर कॉज MI, आपके अब्बा को पता लग गया कि क्या हरकतें करते तो उनको हार्ट अटैक हो जाएगा. जेलसिटाबिन खाने से मुंह जल जाता है, एप्थस अल्सर्स. M-tricitabine कॉज ट्री लाइक पिगमेंटेशन ऑन palm and soles. Didanosine, दीदी को पेनक्रियाटाइटिस हो गया. Stabudin cause peripheral neuropathy. So PNS, peripheral neuropathy caused by stabudin. Efavirenz खाने से weird behave करेगा, weird. It will cause altered mental status. Nevirapine पीने से liver खराब हो जाएगा, hepatotoxicity. And Navirs cause lipodystrophy syndrome. That means metabolic side effects. Then lastly, we need to know about antidotes. I hope you all know by now. Beta blockers, glucagon. Organophosphate poisoning is atropine. Benzodiazepine is flumazanil, same is zolpidem also flumazanil. Cyanide poisoning, hydroxocobalamin. Methanol poisoning, it is fomepizole, and if that is not given, ethanol. Same is for ethylene glycol, fomepizole first, second choice is ethanol. Iron poisoning, acute iron poisoning, desferrioxamine, and chronic iron poisoning, deferripiron. Acetaminophen or paracetamol, everyone knows, N-acetylcysteine. Valproate is L-carnitine. Atropine is physostigmine. Heparin, protamine sulfate, and warfarin, vitamin K. So these antidotes are very important. So lastly, new drugs. New drugs, we already discussed duty ka after. Duty, we already discussed potentiator, are my duty to open the channel, and Tiza and Vanzacaftor are correctors for cystic fibrosis. Then sulopenem is a new carbapenem, just like meropenem, it is indicated in UTI. Olezasiran, arsen is antisense oligonucleotide, and the name says oil ESA. So it will make oil easy. Oil means chylomicron. So it is used for chylomicronemia. Carbidopa, phoslevodopa, these are the products of carbi and levodopa. They are used for on-off phenomenon in Parkinsonism, late Parkinsonism. Atrasentan, sentan means endothelin antagonist, ANT-N, the name ends with ANT-N. Endothelin antagonist, they are for primary IgA nephropathy. Fitusiran is a small inhibitory RNA. Siran is small inhibitory RNA. Fitu says it fixes insufficient thrombin. When thrombin is less, more bleeding. Where bleeding? In case of hemophilia. So used in hemophilia A or B. Then Geptosidan is a new drug. It's a topoisomerase inhibitor. It is indicated again in UTI. Topoisomerase inhibitor of bacteria used in UTI. Sujitrigine is like lamotrigine, sujitrigine. It is blocking the sodium channels. So it is used for pain. Landiolol is a new ultra short acting, in fact, the shortest acting overall beta blocker. It is a cardioselective beta blocker. It is indicated in supraventricular tachycardia, including atrial fibrillation and flutter. Then xanomeline and trospium is a combination of a cholinergic with anticholinergic drug. The anticholinergic drug do not cross the blood-brain barrier, so cholinergic action will be seen only in brain. So it is used for schizophrenia. Resmetirom, it is a metabolic modulator. It is basically acting on the thyroid hormone receptor beta. Thyroid hormone receptor alpha is present in heart and other places, but beta only in the liver. So it will affect the metabolism in the liver, and it is used for NASH, non-alcoholic steatohepatitis. Clear? So these are the important topics. Very quickly, I have told you. So all the very best for the exam. Thank you.
Hi friends, I hope all of you are pretty much geared up for INI-CET exam taking place tomorrow. My best wishes for the same. I just want you to have a look at certain important topics which may be asked in the exam. First one is going to be with regards to the topic of cell injury. You just need to have a quick recap about the different patterns of cell death and the salient features. From the topic of immunity, please do have a look at the pathogenesis, the reasons for the autoimmune disorders, the different antibodies which are seen, and the kind of images that are seen with respect to the specific IF patterns. The third is with regards to neoplasia, have a look at the different genes and their association with the different types of malignancies. Not to forget about the examples of the tumor markers which will be asked in the exam. The fourth and an easy topic asked in the exam is the topic of leukemias and lymphomas, wherein they ask you about the CD markers and the presentations. The next one is going to be with regards to blood banking, with special emphasis on the blood and its products, the shelf life of the products, and it shall also include the different types of complications which may be associated with blood transfusion. Don't forget to have a look at the vacutainers, the kind of anticoagulants present in them, and their typical uses in the clinics. The final one is going to be from the topics of the cancers, particularly lung cancer and renal cancer, with regards to the specific findings in association with the different subtypes of each of these cancers. Right? Not to forget, the last but not the least, we will need to have an idea about the important questions which have already been asked in the exam pertaining to the histological finding, pertaining to the diagnostic finding in context of a tumor like breast cancer. All the very best from my side. I'm sure you're going to be doing exceedingly well in the exam tomorrow. Best wishes.
Hello, everyone, and welcome to the Microbiology high yield scenario. So, INI-CET is just around the corner, and there are these top 5 topics that I think can potentially come in this exam. So, let's begin with the first question. The first question is: which of the following statements regarding the bacteriological culture media is or are correct? So, one question on culture media is definitely going to come. So, let's see which is correct. Culture media contains malachite green that acts as an inhibitor for most contaminating bacteria. That is a true statement. Malachite green is what makes it selective for algae media, what makes it selective for Mycobacterium tuberculosis. McConkey agar is a differential media. Yes, we all know that it differentiates between lactose fermenter and non-lactose fermenter, and it is a differential media. So this is a true statement. Bile salts in Salmonella Shigella agar is responsible for differentiating between Salmonella and Shigella. This is actually a false statement because bile salts actually make other organisms get inhibited and selectively kind of enriches these organisms, which is your Salmonella and Shigella. So this is a false statement. It is not for differentiating between them, but rather inhibiting the other organisms. So these two can be enriched. So then we have the chocolate agar is an enriched non-selective medium prepared by heating blood at 80 degrees Celsius. Yes, this is a true statement. So there is a range from 70 to 80 degrees Celsius is the range that we have for heating of the blood. So we have all the 3 statements that are true. That is going to be A, B, and D. So answer is going to be option number C, right? A, B, and D are the correct statement. C is not the correct statement. Moving on to the next one, we have a question related to a 65-year-old male has UTI with Klebsiella pneumoniae. Now, the isolate is found to be sensitive to meropenem. That means carbapenem is working. So carbapenem sensitive and amikacin, which is fine. We're basically trying to think about the beta-lactams here. But resistant to ceftriaxone. Ceftriaxone is the 3rd generation cephalosporin, right? And aztreonam. Again, aztreonam is a monobactam. Now, very important, remember when we were talking about the Ambler classification, in the Ambler classification, there is only one group in which the monobactams are also resistant, right? Rest all the monobactam, that is the aztreonam, is going to act on all the other beta-lactamases except one, which is your extended spectrum beta-lactamases. Monobactams can't act on extended spectrum beta-lactamase, but your carbapenems can, because the carbapenemases are the ones that inhibit it, right? It is the carbapenemases that inhibit extended spectrum beta-lactamases acts on penicillin, cephalosporins, and monobactams versus the other ones, which is going to be carbapenemases. They act on just these carbapenems. So going back, looking at it, that astronome is also resistant. That means there's only one group which is also making astronome being resistant. That is going to be your resistance pattern strongly indicates extended spectrum beta lactamase, right? Rest all of them, if you look here, the carbapenem will be resistant, but the astronome will act. Here also astronome will act, and here also astronome will act. So it's not resistant. So the only one that is resistant is the ESBL. Okay, moving on to question number 3. Which of the following describes the key characteristic of major MHC1 complex? Basically, MHC1, we all know, are the ones that are the presenting cells, right? So they are expressed exclusively on professional antigen presenting cells. That is actually a false statement. It is present on all nucleated cells, right? All nucleated cells, not just the professional antigen presenting cells like the dendritic cells and the macrophages. So this is a false statement. They present exogenous antigens to T lymphocytes. That's false. They actually present the endogenous antigens, like the viruses and all. These are the ones that are the endogenous antigens. They are presented to the lymphocytes. They are composed of alpha chain and non-covalently associated beta 2 microglobulin. This is actually a true statement. So we all know that they are made up of these three: alpha 1, alpha 2, and alpha 3. And then we have this beta 2 microglobulin. So this is a true statement. This is the structure of the MHC1, and it activates B lymphocytes. Again, this is wrong because we all know that it activates the T lymphocytes, right? So the answer here is going to be option number C. So that is the true statement. Moving on to the next one, we have a 25-year-old male with urethral discharge. Gram stain is showing this image below, and most common complication associated with this organism. Now, first, let's identify what is the organism. I'm seeing these really extremely small gram-negative foci. Gram-negative foci with a urethral discharge has to be related to your gonorrhea, right? It has to be related to your Neisseria gonorrhea. And we all know that apart from causing urethritis, the most common complication that Neisseria gonorrhea can cause, it's going to be the epididymoorchitis, right? It is one of the most common complications, that is your epididymoorchitis. Now, some of you might think that, ma'am, Waterhouse-Friderichsen syndrome, this is something with Neisseria meningitis, guys, right? Meningitis, not so much with Neisseria gonorrhea. Then we have others like pelvic inflammatory disease and Fix-Hughes-Curtis syndrome. They are not the most common ones, but they are also present, right? So the answer is going to be option number A. Moving on to the next one, we have assertion reasoning. Vibrio parahemolyticus is the leading cause of gastroenteritis in coastal regions. This is actually true. And the virulence factor associated is the thermostable direct hemolysin, which is mediated by the Kanagawa phenomena. So this whole statement is coming out to be true. This is the beta hemolysin, which is your thermostable direct hemolysin, which is responsible for the Kanagawa phenomena. Now, the reason that they're giving is that the Kanagawa phenomena is specialized test where the organism is inoculated on the Vagatsuma agar, and the strain produces beta hemolysis. Again, yes, this is a true statement, right? So this thermostable direct hemolysin is mediating the Kanagawa phenomena, and this Kanagawa phenomena is a special type of this on Vagatsumagar. All of this is correct. So A and R both are true, and R is the correct explanation for A, right? Because we know that it is causing beta hemolysis of this Vagatsuma agar, which is a blood agar, which is containing high amount of salt concentration, eliminating all the other organisms and selectively increasing this direct hemolysin of Vibrio parahemolyticus, then showing a beta hemolysis of the Vagatsuma agar called as the Kanagawa phenomena, right? Okay, now we have to match the following. Let's match the following parasites with their features. So coming to Strongyloids stercoralis, is it an egg with terminal spine, auto-infection, neurocystic sarcosis, barrel-shaped eggs? We all know that it causes auto-infection. That whole chest mnemonic in that S is for the strongyloids, which causes auto-infection. So we have A for 2. So all the others are anyway out, but let's still go. We have Schistosoma hematobium. Hematobium produces these terminal eggs. Then Trichuris shows these barrel-shaped eggs, and finally Tinea solium with your neurocystic sarcosis. So D is going to be 3. So A to B1, C4, D3, it's going to be option number B. Right, moving on to the next one, we have which of the statements are true about the torch infection. So we all know torch is a group of congenital infections, the organisms that are causing some kind of congenital disease. So let's see which are the true statements. Periventricular calcifications, chororetinitis are highly suggestive of congenital cytomegalovirus. Remember, guys, V for cytomegalovirus, V for virus, V for the ventricular, periventricular calcification. This is a true statement, right? Serum IgM antibodies in newborn serum for a torch agent confirms congenital due to the inability of the maternal IgM antibodies to cross the placenta. Again, a true statement because IgM can't cross. So we do the IgM antibodies in the newborn's serum because IgG can be transferred. So that doesn't help. IgM, if is detected in baby's serum, it confirms that it is going to be a congenital infection. So true statement. Congenital toxoplasmosis presents with a striate of chororetinitis, hydrocephalus, and intracranial calcifications or intracerebral. Yes, again a true statement. This is the triad that you see in congenital toxoplasmosis. Congenital rubella syndrome has characteristic ocular defects like cataracts and salt and pepper retinopathy. Again, a true statement. We all know that congenital rubella, we have the triad of the eye, sensory hearing loss, and the patent ductus arteriosus. So if you see all the options are correct, so our answer is going to be option number D, right? Okay, moving on to the next one. We have 30-year-old accidentally struck by a needle contaminated with blood. With chronic hepatitis B infection, patient is HPS positive. He completed his vaccination 5 years ago, and post-vaccination serology is showing that the titers are 15 milli international unit per ml. What is the most appropriate immediate post-exposure management? Because the titers are more than 10 milli international unit per ml, and this person is a responder. This person is protected, so we don't have to do anything because the titer is going to be more than 10 milli international unit per ml. So we don't have to treat this patient. So we can just kind of treat for other diseases, but not for hepatitis B because this person is a responder. Okay, moving on to question number 9. We have HIV patient, severe dyspnea, bilateral diffuse infiltrates, chest X-ray of the chest X-ray undergoes bronchoalveolar lavage, and now bile fluid is showing the Gomori methenamine silver. Guys, the moment you see this word Gomori methenamine silver in an HIV positive patient with interstitial infiltrates in the lung, you always have to think about the pneumocystis jirovecii, right? So now they are saying what morphology will you see under the microscope for this? So we know that pneumocystis we can't culture, we can only do histopathology, and we see that one very, very particular thing which is called as the crushed, right? Crushed ping pong ball appearance. So either they might give you the word GMS stain in the question or they might give you the picture of this. So the answer is going to be C, that is crushed ping pong shaped bodies that stain either black or brown. Let's see the other intracellular budding yeast cells with narrow base budding in germ tubes. So narrow based budding is something that is for histoplasma, by the way, and germ tubes is for candida. So this is not going to be the answer. Thin walled large spherules containing endospores, again something which we see in coccidioides, but not something where we are going to see the GMS staining. Broad based budding with thick capsules, again your blastomyces. So all of these are there, but it is not something which is specific for your pneumocystis pneumonia. So answer is going to be option number C. Going on to the last question, we had a diabetic ketoacidosis patient who had facial pain, periorbital swelling, and necrosis on the hard palate. The moment you see diabetic ketoacidosis with facial pain and necrosis, you always have to think about the group that is going to be your mucormycosis, right? Or your zygomycetes causing mucormycosis. Now, biopsy of the nasal tissue shows fungal elements. This is the image. Which of the following is the primary antifungal agent used for the initial treatment? Now, if we see here, we've already firstly made the diagnosis of mucor, but we are also seeing these broad, aseptate, right? Wide angle branching hyphae. So all of this is going to point towards our zygomycetes or mucormycosis is what we have called it, right? So the drug of choice when it comes to this, it's going to be your liposomal amphotericin B. This is what we end up giving. The best treatment would be surgical removal. After that, we have to give the liposomal amphotericin B. So thank you guys. These are all the 10 high-yield topics that I think can potentially come in the INI-CET exam. And all the best from my side. I hope you come out with flying colors. So all the best.
Hi students, let's start with the last day class of forensic medicine for the INI-CET. Let us discuss the most important topics. Okay, let's discuss the most important topics. Inquest, police inquest, 194 BNSS. Magistrate inquest, 196 BNSS. Done in which conditions? Dowry death, exhumation, and custodial death. Earlier, custodial death was by judicial magistrate, other two were by executive. Now, new law, all by executive magistrate. Okay. Now, crystals in the stains, dark brown rhombic crystals can be of Florence test, that is for semen, or it can be for hemin test, that is hematine chloride, for blood. Yellow needle-shaped crystals are Barbario test for semen. Pink feathery crystals are Takayama test or hemochromogen test. Why in Takayama? Why in feathery? Now, bomb blast injuries, primary blast injuries occur due to high pressure waves. Main organ injured is tympanic membrane, followed by lungs, followed by GIT. GIT is more commonly injured in underwater blast. Secondary blast injury occurs due to flying of small object. It leads to multiple small abrasions, contusion, lacerations. That is Marshall's triad. Marshall's triad. Tertiary blast occurs due to high velocity wind. Victim is blown away. Quaternary blast injuries include all other injuries. Example, respiratory injuries due to gases, flash burns, traumatic asphyxia due to building collapse, traumatic asphyxia due to building collapse. Okay, autopsy technique all together is lead to lay. L for lead to lay, L for large. This is how you remember. This is also called N-mass technique. It is done in infants, then taken out in separate blocks is Gon's technique, this N block. Then each organ one by one is Virchows. It is the most common. Dissected in situ is Rokitansky. So S in Rokitansky, S in situ. It is done in highly infectious diseases like HIV, COVID, etc. Then sexual paraphilia, sending of pain, infliction of pain is sadism. Opposite of sadism is masochism. Watching people is voyeurism, also called peeping Tom, also called scoptophilia. Scop means to see. Rubbing against other person in crowded places is voyeurism. Double T together is crowded. E for exposure of genitalia is exhibitionism. Obscene speech is satologia. Okay. Then starvation death, gallbladder is distended. Atrophy is seen in all organs except brain. Last fat to disappear is that of buccal fat. And please remember, energy during this time is provided by ketone bodies. Okay. Then criminal responsibility of mentally ill is given under 22 BNS. It is derived from McNaughton's rules. There are other tests also like irresistible impulse tests, Durham's rule, Curran's rule, American Law of Institute test, and doctrine of partial responsibility. You have to remember the definition of Durham's and Curran's. It's very simple. D for Durham's, D for product of mental disease or defect, C for Curran, C for don't have the capacity to conform to the requirements of the law. Then color of postmortem, usual color is purplish red, and cherry red is seen in carbon monoxide, cyanide, and cold. Cold is hypothermia death. So C, 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 and C. But if you have to choose one, for cherry red, the best is carbon monoxide, and cherry red color is very similar to bright red or bright pink. Okay. Whereas dark chocolate brown color is seen in methemoglobinemia caused by drugs like nitrites, nitrates, benzocaine, dapsone, aniline. Okay. Then please remember, in topa we see garlic-like smell. So thallium, organophosphate, phosphorus, and arsenic. For fishy. For fishy. So aluminum phosphide and zinc phosphide have fishy odor. Cyanide and hydrogen cyanide have bitter almond odor. And in cannabis, we have smell of burnt rope. Okay. Then antidotes. For both methyl alcohol and ethylene glycol, the main antidote is you give omeprazole, also called 4-methylpyrazole, or ethyl alcohol. But omeprazole is best. Then you also give plus sodium bicarbonate for acidosis, and third, plus you give dialysis. For benzodiazepine, you give flumazenil. Opioid, you give naloxone. Datura, you give physostigmine. Organophosphate is a cholinergic poison, and for all cholinergic poison, the main treatment is atropine. Then you give pralidoxime, and then you give diazepam for seizures in this order, A, B, D. Okay. Then carbamates, you don't give pralidoxime, you give only atropine and diazepam. Phosphorus, 4 is there, so CuSO4, Am4, phosphide, aluminum phosphide and zinc phosphide, magnesium sulfate. M for methemoglobinemia, we give M for methylene blue. For cyanide, the best antidote is hydroxylamine. Okay, but other antidotes are, you can say amyl nitrite, sodium nitrite, sodium thiosulfate, and dicobalt EDTA. Dicobalt EDTA. Okay. Then you have to differentiate opiate versus cocaine versus datura versus organophosphate. Opiate will cause very much decrease in respiratory rate, coma, meiosis. Okay. Cocaine will cause increase of vitals. Okay. Then there will be arrhythmias, anxiety, convulsions. In datura also there will be increase in vitals, anxiety, but most important feature datura and cannabis can have similar features, but the main feature of datura that will differentiate is it will be totally dry. In organophosphate, it will be a leaking person, dumbbells, all body secretions increasing, diarrhea, diaphoresis, then urination, meiosis, bradycardia, emesis, lacrimation, salivation. So basically, leaking person is organophosphate. Okay, neurotoxics. If we talk about these snakes, neurotoxic symptoms with plus local symptoms, that will be cobra. Only neurotoxic symptom with minimal local symptoms, that will be crate. Vasculotoxic symptom but no neurotoxic symptom is saw-scaled. Both vasculotoxic and neurotoxic is Russell's. Russell is rascal. So it causes both vasculotoxic and neurological. Okay, thank you very much and all the best for your exam. God bless you all. Thank you.
So hello dear students. So these are the few topics that you need to revise just before going to INI-CET. Just a quick review we'll go through. And so stage staging, you have grade 1 on the malleus and grade 2 on the incustipis and grade 3 on the promontory, grade 4 atelectasis. And next coming tuning folk test, Rini positive. So if right SNHL, Rini positive, and the conductive loss, Rini will be negative, and paper will lead less towards affected ear in case of conductive and normal ear in case of SNHL. In unilateral severe SNHL, Rini will be false negative, right? And the WHO classification of the hearing losses you need to go through once. And the normal conversation is around 60 decibels. If you shout, it will be around 90 decibels. And coming to the pure tonodiometry, if you are getting two curves in this normal range, that is normal. If there is a gap in between two, bone conduction normal, ear conduction abnormal, conductive hearing loss, both are in the abnormal range with no gap, SNHL. Both are in the abnormal range, but within the gap, well, having a gap, that is mixed loss. So these are the audiograms, various audiograms you need to remember. 4 kilohertz deep noise induced hearing loss, Carhart's notch, okay, 2000 hertz ascending linears, and a trough shaped in the acoustic neuroma, downsloping in presbycusis. Otitis media with effusion will have B type and is usually associated with adenoid hypertrophy. So frequently associated with cold episodes. And coming to outer hair cell and inner hair cells. So there are few differences, 3 to 4 rows, 1 row of inner hair cell. So otoacoustic emissions are produced by outer hair cells. Most important point, outer hair cells modulate the function of inner hair cells. And coming to the autoacoustic emissions, along with the beta, these are the tests done for screening of newborn hearing, right? So this is the most common test, right? And coming to the beta, E. coli. So you need to remember various waves accordingly. Wave 5 is most prominent, right? And coming to the sequence of auditory pathway, E. colema is the mnemonic you need to remember. And coming to the auditory neuropathy. So this is a retrocochlear lesion where your beta will be showing the auditory nerve lesion. So auditory neuropathy is mostly congenital and they will be having retrocochlear hearing loss. And these are the various multiple. If you are getting aplasia, that means complete absence. And scabies dysplasia, pars inferior parts will be absent. Alexander basal coil and Mont dysplasia, 1.5 tons of cochlea will be there. Coming to BPPV, most common cause of vertigo, on changing the position, immediate short duration of episode of vertigo will be there. And Dix-Hallpike is diagnostic and Epley is therapeutic. 45, 30, 90, 90 is the sequence of angles in Epley. And coming to the cochlear implantation, this is less than 6 years is the age limit for prelingual deaf. With postlingual, there is no age limit. So auditory nerve should be normal. This is a very important criteria, right? So first, before going for cochlear implant, 6 months of hearing aid trial is definitely done. If it is failed, then you will go for cochlear implantation, right? So these are the various parts. You have a digital processor microphone here, and this is the transmitter, this is the receiver, and this is the intracochlear electrode, and this one is your grounding electrode. Right? This is concha bullosa pneumatization of middle turbinate, agar-nazi anterior most ethmoidal air cell, and you have the ethmoidal bulla, largest ethmoidal air cell, and you have the halar cell at the floor of the orbit, and Onodi cell near the optic nerve. Little area is the most common set of epistaxis, anterior ethmoidal, sphenopalatic, greater palatina, superior labial branch of facial artery. So these 4 arteries form plexus at the anterior inferior part of the septum. Posterior ethmoidal artery does not take part in the formation of the plexus, right? And coming to the rhinosporidiosis, so this is usually rhinosporidiosis, you have a sporangium. On histopathology, you will be seeing sporangium, strawberry-like mass with epistaxis. So sporangium with endospores will be seen on histopathology. So if you take the site of drainage, so into the sphenoethmoidal recess, sphenoid sinus will be draining. Into the superior meatus, your posterior ethmoid. Into the middle meatus,
The anterior group, your frontal, maxillary, and adjacent point will be draining into the middle meatus. Into the inferior meatus, nasolateral duct will be draining. And coming to the nerve supply of the larynx, above the level of the vocal cord, inside sensory supply is by internal branch of SLN. Below the level of the vocal cord, it is by recurrent laryngeal nerve. If you take piriform fossa, it is by SLN. When postcord area is by RLN, right? Now coming to the worst prognosis. So Simon's law states that worst prognosis is seen in partial palsies rather than complete palsies. So following total 30, if without paralysis, during phonation, both vocal cords adduct, and during respiration, both vocal cords abduct. Now see this vocal cord, see unilateral, one side paralysis is there, vocal cord is in fixed position, normal vocal cord is moving away, adequate airway. So in unilateral paralysis, no breathing difficulty, but on phonation, there is a gap, phonatory gap is there. So what breathy voice will be there? In bilateral paralysis, both will be in paramedian position, so respiratory difficulty will be there. And coming to phonation, not much difficulty or strangulated voice will be there. Post laryngectomy rehabilitation, the best method is by tracheoesophageal prosthesis. This is electrolarynx and artificial implants, Chicago implants. These are in the experimental stages. And coming to the adenoids, so mouth breathing, snoring, dry mouth, pharyngitis, high arched palate, serous otitis media, and sinusitis and sleep disturbances. So many complications are there due to adenoids. So these are the features of adenoid hypertrophy. If a foreign body is fixed in the larynx, it aligns anterior-posteriorly. So on AP view, you see the side of the coin, and on lateral view, you see the face of the coin. But if the coin is fixed in the esophagus, it aligns side to side. So on AP view, you will see the face of the coin. On side view, on lateral view, you will see the side of the coin. And coming to if the foreign body is in the trachea, palpatory third will be there. And if there is there in the bronchus, and that side air entry will be reduced. And if it is in the larynx, if larynx gets struck up, already narrow airway, so glottis area, it is narrow airway. So in the glottis, if it's fixed, the life-threatening condition. So larynx is led to voice production, so voice change will be there. So now if the child is less than 1 year, don't go for hemorrhage. If the child is more than 1 year, you can go for hemorrhage. If the child is unresponsive, start CPR. And if the child is responsive, just go for, if he is less than 1 year, 5 back slaps plus 5 chest thrusts. More than 1 year, you can go for Heimlich maneuver. So structures passing between superior and middle come from down above. So you can see down below here, recurrent laryngeal nerve, the last gap. So you have 3 constrictors and esophagus. So draw them continuously. Last one is RLN, just above that is SLN, 10th nerve branches. Because RLN goes down below, and the 9th nerve is present in between superior and middle along with stylopharyngeus. Between skull base and superior constrictor, you have sinus of Morgan, eustachian tube, which muscles and arteries are present here, right? And now coming to JNA, sphenopalatine foramen behind the middle tablet. Eustachian tube lies behind the inferior tablet. Hallman-Miller sign, anterior of posterior maxillary wall. This is seen in adolescent males. And epistaxis, severe recurrent profuse epistaxis, spontaneous episodes are seen. And IL mirror is straight and nasopharyngeal mirror is curved. And so this ends your, okay. So the quick revision of the INI-CET important topics for ENT. And I wish you all the best for your exam. So stay cool, just concentrate, be alert, just read all the options carefully and then only go for answering the questions. All the best, and we'll meet in the recall session. Thank you. Bye.
Hello, dear students. We are in the final preparation for INI-CET exam. I hope your preparation is on track, and all the best wishes from my side, Dr. Gaurav Nagpal, Faculty of Ophthalmology. Let us take a quick sprint across the various topics in ophthalmology that are there. I have made this PPT based on that there are 1 or 2 slides on each and every topic. So let us start with the first topic that is there in the optics. Please remember the various terminologies that are there, like astigmatism, anisometropia, emetropia, ametropia. Okay, these are various terminology on the MCQs can come. Okay. Next is on the corrected lenses. Please remember in myopia, the lens that we use is the concave lens, whereas in hypermetropia we use convex lens, in astigmatism we use a cylindrical lens. Okay. Astigmatism, we have to remember that it can be of 2 types, with the rule and against the rule. With the rule is that the vertical is steeper and horizontal is flatter. This is with the rule. Okay. Against the rule is when the vertical is flat and the horizontal is steep, that is against the rule. In case of numerical values, minus at 180 and plus at 90 is with the rule, whereas minus at 90 and plus at 180 is against the rule. Okay. Remember the ray diagram? The ray diagram is Sturm's conoid. The Sturm's conoid denotes the ray diagram, which is there. And based on Sturm's conoid, we can classify astigmatism into a simple myopic or simple hypermetropic, compound myopic, and compound hypermetropic, based on whether the rays are focused on the retina or behind or in front of the retina. So in one, this is one on the retina, and the other is behind or in front of the retina. If both the rays are in front, then it is called as compound. Okay. If one set of rays is in front and one set of rays is behind, then it is mixed astigmatism. The key point to identify mixed is you have opposite signs, plus and minus, and the cylindrical value is going to be more than the spherical value. This is the key point to identify the mixed astigmatism. Please remember this. Okay. Next is based on the refractive correction options. One common MCQ that comes is on the eligibility criteria, where we know it is going to be that patient age is more than 18 years and refraction stable for 1 year. That is the eligibility criteria for any sort of refractive correction. Okay. Refractive corrections can be cornea-based surgeries or can be lens-based surgeries. RK is an incision-based surgery. Okay. PRK and LASIK are excimer-based surgeries, excimer laser-based surgeries. Smile and silk are femtosecond laser-based surgeries. Smile and silk are hot topics. There you are doing a lenticule extraction. You are not using any excimer laser. This is your smile and silk surgery. These surgeries on the cornea are up to -12 diopters, and for 6 diopters, astigmatism and hypermetropia, that is the limit. In case the patient is having more than this, a refractive error which is more than this, you have to do a lens-based surgery. For patients who are unfit for LASIK surgery also, like very, very thin cornea or maybe corneal dystrophies, there also we can opt for a lens-based surgeries. Okay. Lens-based surgery common is phakival, that is ICL or implantable contact lens. Remember this. Okay. These are one of the refractive correction options. Refractive control options. Remember, we have done this in the control part also, refractive control options. That is, there is low dose atropine. What is the percent that is used is 0.01% to 0.05%. That is the low dose atropine for refractive control option that is used in pediatric cases. Okay. Next chapter, that is the lens. Lens development is important. Then in the lens, you have cataract, various types of cataract, congenital cataract, senile cataract. Then these are the common metabolic cataracts on which the MCQs are commonly asked. Okay. Wilson's disease, a very, very hot topic on which how to diagnose Wilson's disease, what are key findings, hepatolenticular degeneration, flapping tremors, your MRI finding. Okay. Then the gene, chromosome 13, ATP7B gene, and autosomal recessive. Then in ophthalmology, you have KF ring, and Wilson's disease has a sunflower cataract. So sun, remember this. Okay, very easy to identify. It can come as an image-based question also, where they give you this image, and there can be a long question, and they ask you the MCQs. In case of sugar disease, that is diabetes, S for sugar, S for snowflake cataract, and S for sorbitol metabolism accumulation. Okay, this is there. In case of galactosemia, you get an oil droplet cataract. Galactosemia can be because of 2 enzymes, galactokinase enzymes and GP-UT enzyme. In galactokinase enzyme deficiency, you can get a lamellar or zonal cataract also. GP-UT characteristically leads to this oil droplet cataract. But galactosemia, you should remember galactoil. Oil is oil droplet cataract. It's a reversible type of cataract. Okay, it's a reversible type of cataract. Let's say by dietary modification, the cataract can be reversed. One very common question that is asked is on the complications of cataract surgery. Various steps of cataract surgery can be asked. What solution is used, like balanced salt solution is used in cataract surgery, that can be asked. The most common complication, it can come as an image-based question. This kind of image can be given. This is the PCO formation, also called as secondary cataract, also called as after cataract. The laser that is used is the ND-YAG laser to create a hole in the capsule, that is capsulotomy, posterior capsulotomy. Most dangerous complication we know is infection, that is endophthalmitis. The most common organism that is there is the Staphylococcus species. Second is strep species for patient presenting late, that is more than 6 weeks later. Okay, the patient that present late, the organism is P. acnes. What are the clinical findings that are there? Increase in pain. So increase in pain, decrease in vision, and increase in redness. These are the three cardinal signs which are there, which can indicate patient is getting endophthalmitis, infection in the vitreous cavity post surgery. Okay. The most important step that is uses povidone iodine on the conjunctival sac, on the surface of the iris, to clear off all the commensal bacteria. You use povidone iodine just pre-operatively. Okay, not as an intra, pre-operative. This is regarding cataract surgery. Next is coming to glaucoma. Glaucoma is an optic nerve disease with the triad of increase in IOP or normal IOP, optic nerve changes, and visual field defect changes. Optic nerve changes and visual field defect changes, you should be able to identify. Those are there. There are primary open angle glaucoma and primary angle closure glaucoma. These are there. Okay. In case of congenital glaucoma, which is ophthalmos, please remember the bullseye, the eyeball is increasing in size, it is expanding. You get horizontal half striae, corneal edema, haziness of the cornea, and the triad is your photophobia, lacrimation, and blepharospasm. This is the triad for ophthalmos. Okay, treatment is surgical. In case of adult glaucomas, secondary glaucomas which are there, these can various image-based questions can come. Pseudo exfoliation glaucoma, where you have this kind of target sign, which is there. Neovascular glaucoma, new vessels, that is with the mnemonic Devi's eyes, red eyes, Devi's eyes, which are there. Pigment dispersion glaucoma, you get this kind of Krukenberg spindle, that is pigment on the endothelium. And malignant glaucoma, it is seen after an intraocular surgery. It is not a malignancy, it is because of it is not responding to any treatment. And the drug of choice here is atropine. All other glaucomas, the atropine is contraindicated. Only a malignant glaucoma, also called as inverse glaucoma, you use atropine as the drug of choice. The various questions can come on drugs. Okay, remember carbonic anhydrase inhibitors, alpha agonists, beta blockers, they reduce the aqueous production. The drugs which increase the drainage, they are the prostaglandin analogs, ROC inhibitors, they increase the drainage, they increase the outflow. Okay, and myotic because they constrict the pupil. Okay, coming to lasers, trabeculoplasty, it is used in open angle glaucoma, it is by argon and dyed laser. Laser iridotomy, otomy is creating an opening. It is done in angle closure glaucoma. This is how it is used, and the laser that we use is ND-YAG laser. Okay, move on to the next topic, that is on cornea. Remember the various layers of cornea, various investigations that we do in cornea, the fluorescein dye, the other lissamine green and rose bengal dye, FLR, that is the sequence there. Remember the corneal ulcers, the bacterial ulcer, the viral ulcer, the fungal ulcer, and the acanthoid ulcer that can be asked. Okay. One very common disease is keratoconus, which is quite increasing in general population. So I believe it's a hot topic. It should be asked in INI-CET because as the myopia is increasing, increase in keratoconus is also there. Okay, it is because the conical cornea, that is keratoconus. So what kind of astigmatism there? It is an irregular myopic astigmatism is the kind of refractive error that is found in keratoconus. There is increase, obviously there is increase in the corneal curvature, and as the cornea curvature increases, the cornea tends to become thin. And because of thinning, you get these Vogt striae, vertical striae, V for Vogt, V for Vogt striae, Munson sign, Rizzuti sign, Fleischer ring, that is the iron deposition ring. On rectoscopy, you see a scissor or a yawning reflex like this, and an oil droplet reflex on a distant direct ophthalmoscopy. Coming to treatment for keratoconus, please remember this is C3R, this is Intax, and in case these don't work, then you do a DALC, deep anterior lamellar keratoplasty, that is corneal transplant, which is the anterior corneal transplant. Okay, so these are the various options for treatment for keratoconus. And coming to corneal transplant, which is again an important topic, eye donation is cadaveric eye donation. Time period for donation is within 6 hours of death. Complication, remember, Krashmer spots and Khoda-Dose line. That is the complication, rejection which is there. And the most common complication is astigmatism. We do storage media, MK media, K-sol media, Optisol media, various media that are used. And the suture that is used is a 10-0 monofilament suture that is, okay. Full thickness graft is a PK graft, peptide characteristic. Isothickness graph can be these types, that is ALK. Okay, DALK is deep anterior laminar character velocity, and then you can have a DSEC, that is Descemet's stripping automated endothelial character velocity, and Descemet's membrane endothelial character velocity. These are the posterior character velocity. So anterior and posterior. Posterior two types, that is DSEC and DMEC. Okay, these are two. Remember, in every ophthalmology exam, there has been some bouncer which has always been there. Okay, so this is my bouncer to you. In exam also, you might get a bouncer. So in case you get a bouncer, what to do with the bouncer? In cricket, you give respect to the ball and you just let it go. Similarly, in exam also, in case you get a bouncer, please accept it and do not panic at that moment. Just respectfully let that question pass. Okay. Here is my bouncer in this in revision. What is this? This is keratoprosthesis. Keratoprosthesis. As the name is telling, it is prosthesis on the cornea. See here, as you can see, there are sutures which are there, and then you see some plastic ring like structure which is there. It is made from the dentures. Okay, so in patients who have had failed corneal transplants and are blind but have a normal retina or a normal optic nerve, in them we can do this kind of keratoprosthesis. These prostheses have this kind of optical stem. They have a carrier unit and they have a titanium ring by which this is sutured to the eye of the patient. Okay. The most common is osteoodontokeratoprosthesis, OOKP. OOKP, osteoodontokeratoprosthesis. This is a prosthesis used for patients who have bilateral corneal blindness. Otherwise, their eyes have a good retina. Okay. This can be a topic which can be asked. It is not an undergraduate topic, but this can come as an MCQ, as a bouncer. Okay. Moving to the next topic, which is conjunctiva. In conjunctiva, we can get various these image-based questions. These image-based questions can be this. This is the flectin which is there. Okay. Then you have this image which is the pingicula. Pingicula is going to be away from the limbus. This is going to be at the limbus. This is limbus. This is away from the limbus. Okay. You have a fleshy mass. This is a pterygium. The surgery for pterygium that is there is the perfect surgery, that is used to prevent the recurrence of pterygium. Okay. Then you have this limbal dermoid at the limbus, and then you have a dermolipoma or a lipodermoid. They are one and the same things, where the lesion is going to be away from the limbus. It is going to be fatty tissue on the outer canthus of the eye, outer part of the orbit. That is a dermolipoma or a lipodermoid. Please remember, one important differential diagnosis is going to be white dot spot. White dot spot is seen in xerophthalmia. Which stage? X1B. B is white dot spot. Easy way to remember, that is white dot spot. Okay. For next topic, which is going to be neuroophthalm. In neuroophthalm, very commonly you are going to be asked about the visual field defect. It is a hot topic which every student should know. Okay. So this is the bitemporal, that is heteronymous. Hetero is opposite side. If the visual field defects are on the opposite side and it's a heteronymous field defect, then please easily remark the chiasma as the site of lesion. Okay, chiasma as the site of lesion. All other lesions are going to be homonymous. Okay, no matter what, all lesions beyond the chiasma are going to be homonymous. That is going to be the same site. Pi in the sky. Sky is going to be your temporal, S and T, temporal lobe lesions. Pi on the floor is going to be your parietal lobe lesions, F and P. Okay. And at the occipital lobe, you have this kind of field defect because there is dual supply. One is posterior cerebral artery and the other is the middle cerebral artery. So posterior cerebral artery, the P, ulta P, the center will be spared. Okay. And middle cerebral artery, only the central lesion is going to be there. That is the middle cerebral artery embolism. Okay. This is what is visual field defect. You should be knowing about various kinds of pupil anomalies also. Argyll-Robertson pupil, Horner syndrome, then your Holmes-Eddy syndrome, Marcus-Gunn pupil. So these are the various pupil defects that can be there. Apart from this, differential diagnosis, you should remember papilledema and optic neuritis. Papilledema, edema of the optic nerve because of some other disease. Okay, so papilledema is not a disease of the optic nerve. It is some other disease which is manifesting in the optic nerve. So optic nerve visual is going to be normal, color vision is going to be normal, pupil reaction is going to be normal. So everything is going to be normal in case of a papilledema. Okay, the visual field defect is going to be enlargement of the blind spot in papilledema. In optic neuritis, itis means inflammation of the optic nerve. Because optic nerve is inflamed, it will not work. Any inflamed body part does not work. So vision is abnormal, color vision is abnormal, pupil reaction is abnormal, and the visual field defect is going to be a central or a centrocecal scotoma. On perimetry, you will get this kind of visual field defect. Optic neuritis is going to be three types. Papillitis, inflammation of the papilla. Retrobulbar neuritis, retro is behind, bulbar eyeball, retrobulbar neuritis. Neither the patient sees anything nor the doctor sees anything. Very, very characteristic finding. The only finding is going to be vision defect associated with pain. It is not a painful visual field defect. Okay, it is associated with pain of the eyeball on movement of eyeball. So pain is an associating finding. It is going to be a sudden onset, profound, severe visual field loss. Okay. And neuroretinitis, there you have a macular star appearance. Treatment of neuritis is high dose intravenous steroids, and the latest treatment is natalizumab. That is. In case of strabismus, please remember this diagram. There you have to identify the yoke muscle. Okay, yoke muscle just reverse all three. So you have a left superior rectus. So left becomes right, superior becomes inferior, and rectus becomes oblique. That is the yoke muscle. How to identify yoke muscle? In case a question comes on Park's three-step test. Okay. First is going to be identify the hypertrophic muscle. Okay. Let us say that the right eye is hypertrophic. When right eye has gone up, that means the depressors are paralyzed. Or if the right eye has gone up, that means the right eye has normally gone up. This eye has not gone up. So that means this can be paralyzed. Okay. So first step is going to be identifying the hypertrophic muscle. Okay. In the second step, they will tell you about the direction of gaze. Okay. Let us say that the patient is looking towards the left side. So when the patient is looking to a left side, which muscle are going to be involved? These muscles. Okay. Because these are the muscles which are going to look into the left side. So left is this side. So these are the muscles which are going to be involved. And in the third step, they will tell you about the head tilt or head turn. Okay, what happens on head turn? So let us say that there is elevation on the patient looking towards, turning towards head to the right. So when the head turns to the right, head turn to the right, what will happen to the eyeball? This eyeball will turn this side. Okay, there is going to be intorsion. Okay, and this eye will be turning this side. That is because the head turns one side, the eyeball obviously turns the opposite side. So intorsion is by which muscles? The superiors. So this is how the superior muscles are involved. The extorsion is by which muscles? The inferiors. So these are the three muscles to be, these are the inferior muscles to be involved. So if you see in this question, which is there, so you had this as the first step, this as the second step, and this as the third step. So in all three steps, the superior oblique is getting involved. So which of the muscle which is involved? The right superior oblique. So just remember these steps. First, hypertrophic mark, second, gaze mark, and third, turn mark. If you mark this in this diagram, it is very easy to identify. You can solve the Park's three-step test also. Okay. The next question that can come on squint is on the basis of various examinations. Maddox rod, Maddox wing, Word-4 dot test, Hess chart, Lee screen, stereopsis test, binocular gaze of vision. Okay, the three grades of binocular vision. SMP, simultaneous macular perception, fusion, and stereopsis, the depth perception. That is the binocular grades of vision. Okay. In retina, the question that can come is on various anti-VEGF injections. Okay. Bevacizumab is Avastin, which was the first one to be used. Okay. Ranibizumab was the second one, that is Lucentis. Okay, Lucentis, Eva, Beva, Lucirani. Okay, Eylea, that is Eylea. Eylea is aflibercept. Aflibercept. Okay, aflibercept is Eylea, and brolucizumab is Paganax. And the most recent one is Vabysmo, that is Faricimab. These are the various anti-VEGF injections used in any case where you have vascular endothelial growth factor formation, such as diabetic retinopathy, your CRBO, your Eales disease, your ischemic cases. So in wherever you have this, even in ROP, we are using these anti-VEGF injections. So MCQ can come on these anti-VEGF injections. Coming to orbit, in orbital infections, please remember this diagram of orbital septum. Okay. Anything which is anterior will be preseptal, anything which is posterior will be orbital. If there is orbital involvement, there is going to be proptosis, the eyeball will be pushed forward. There is going to be restriction of movement, which is going to be in orbital because it is in the orbit. And there is going to be visual disturbance because the optic nerve will be involved. Anything which is anterior, preseptal, the vision is going to be normal, the orbit, the eyeball placement, there will be no proptosis. So eyeball placement will be normal and there is not going to be any visual defect also, and the movement is going to be normal. So preseptal and postseptal, please remember them. Postseptal can lead to a cavernous sinus thrombosis also. Then there has to be a bilateral involvement, and cavernous sinus can lead to systemic features also. Systemic involvement is going to be there, cavernous sinus thrombosis also. Okay. In orbital tumors, please remember retinoblastoma. Anything which has intraocular calcification is characteristically retinoblastoma. Leukocoria, differential diagnoses are there. Congenital cataract, coloboma, Coats disease, retinoblastoma, ROP, retinopathy of prematurity. Please remember that topic also. Any child born prior to 34 weeks and weighing less than 2 kgs, 2000 grams, can develop ROP. Between 34 to 36 weeks, if the patient has had a ICU stay, okay, blood transfusion, respiratory difficulties, anemia, some sepsis, then the patient can develop. So even 34 to 36 weeks. Beyond 36 weeks, it is unlikely to get a ROP. Okay. Every child has to be, if the patient is suspected to get ROP, child has to be followed up every 2 weekly. First examination is at 4 weeks. If the child is very, very premature, less than 30 weeks, the first examination can be 2 to 3 weeks from the date of birth. Okay, this is what is ROP. Moving on to strabismus, squint. Please remember, for every squint, the first is going to be refraction. Then you give eye glasses or contact lenses. Then you have to do patching for amblyopia. Okay, amblyopia requires patching of the better eye. Okay, patching of the better eye. So amblyopia and prisms. And the third step is going to be surgery. Surgery is going to be the last step. So first is refraction. Second is amblyopia and prisms. And then you have surgery as the last step for strabismus, that is good. Okay. Various lid anomalies. The various glands are there, that is Mammalian gland and Zeiss gland. Zeiss gland can lead to this kind of sty, that is hordeolum externum. Hordeolum internum is Mammalian gland, and a chronic painless swelling is called as chalazion, that is there. Okay, so these are the various problems on the lids. Okay, you can have ptosis, the big question can come on ptosis. Fasanal Sarbat operation, that is tarso-Muller ectomy, was first done for Horner syndrome. It is because of Muller's involvement. Okay, and for even mild ptosis with a good liver traction, you can do a Fasanal Sarbat operation. Okay, for a severe ptosis and a poor liver traction, what are the surgery that is done? It is brow suspension or a sling surgery. Okay, a very common topic which was being asked earlier was not there in the previous INI-CET or NEET exam. That is on ocular trauma. Blunt trauma can lead to this kind of rosette catra, that is blunt trauma. What is this? This is the Vossius ring that can be asked in blunt trauma. Okay, it can lead to hyphema. If the hyphema is total hyphema can lead to this kind of black ball like appearance, that is called as 8-ball hyphema. You can have iridodialysis. This leads to a D-shaped pupil. You can have a cherry red speck kind of appearance. This is your commotio. retinae, or Berlin's edema, which is the differential diagnosis of your cherry red spot. Because of the edema of the retina, you have a cherry red spot kind of appearance. This is ecchymosis, which is there. Then you can have zonular dialysis, where the zonules are broken and the lens is shaking. That is called as phacodonosis, where the lens is trembling or shaking like this. Okay. You can have a question on chemical injury. In case of chemical injury, the most important step is going to be washing the eye thoroughly. Okay, that is going to be the most important first step. Okay, and what is going to be the drug of choice? The drug of choice is going to be steroids. Steroids are the primary mainstay of treatment for any sort of chemical injury. Okay, correct. That is an ocular trauma. Newer drugs, you can get an MCQ on newer drugs. Fenretinide is a newer drug which has been approved for ARMD. It is used for geographic atrophy, where the patients with geographic atrophy have been benefiting with the use of fenretinide. Okay. Low dose atropine, I've already told you, it is being used for a myopia progression. 0.01% is the initial one. Now 0.05% has also been approved. Low dose pilocarpine, earlier 1.25%, now 0.4% has been approved for your presbyopia correction. Presbyopia is because of near age, because of near reduction, because of increasing age. It is presbyopic glasses are a very, very disabling feature. Presbyopia is a very hot topic because many companies are doing research on this topic. Because presbyopia glasses, you have to keep changing with age. As the age increases, the presbyopia correction keeps increasing. So this is pilocarpine, low dose pilocarpine has been approved by the US FDA for presbyopia correction. Okay. These are some of the topics which I think are important from the INI-CET point of view. My best wishes to all of you, and I hope you get some questions from these topics itself. Just remember, during the exam, keep your calm, do your best, don't overthink. It's a common human tendency to keep thinking about, oh, I don't know about this, oh, I don't know about that. Don't let negative feelings come in between. Just keep respecting every question and keep moving forward. Okay. This is Dr. Gaurav Nagpal wishing you all the best from my side, and do well. Hope to see you in the Cerebellum when you succeed.
So friends, this is the final booster dose just prior to your actual examination. I am your very own Dr. Vivek Jain for PSM. So friends, let us start with important things you need to know. Fishbone diagram is a cause and effect model, also known as Ishikawa diagram. In this, all the risk factors are the part of the skeleton of the fish, and the mouth of the fish is the outcome or the disease. So you can see these are the different causes. And ultimately, it leads to effect or the disease. So Ishikawa model. This is known as sufficient component cause model. For any disease to occur, there is one necessary cause, but there are many other component causes. If you look at this particular example, you can see that it is B, which is the necessary cause. It is present in each of the pies, whereas other A, C, D, E, F, G, H, I, so on, they will be component causes. Necessary plus component is sufficient to cause the disease. This model was given by Rothman. Evidence-based medicine pyramid, which was given by David Lawrence Sackett, tells us that at the top is meta-analysis, which is the gold standard of evidence-based medicine. At the bottom of the pyramid, below expert opinions, are the animal research and in vitro research. Correct sequence for randomized controlled trial, when you look, it includes first inclusion and exclusion, who should be there in the trial. You randomize them so that you can eliminate selection bias. This randomization is done while dividing the sample population into experimental and reference group. Then you do blinding of the treatment. One group gets treatment, one gets placebo, or new treatment versus old treatment. And finally, there is analysis. Intention to treat trial is when results are not affected by attrition while final calculation, and they are not excluded, they are included in the final results of RCT. Among all the treatment guideline protocols, you must know that actually the answer lies in the last alphabets: observational studies in epidemiology, systematic reviews and meta-analysis prisma, observational studies in epidemiology, diagnosis of accuracy studies, then recommendations for intervention trials, case reports. So consort you should definitely know. Prisma you should definitely know for your exam purposes. Vaccines and cold chain. Then vaccine vial monitor, which is a cumulative heat exposure marker, is actually a marker of cold chain maintenance directly and potency indirectly. Inner square, when it is lighter than the outer circle, use the vaccine. If it is same color or darker, discard. VVM is of 4 types: 2, 7, 14 and 30. When we look at VVM2, this is for most heat sensitive vaccines like BCG, OPV, yellow fever. These are. And VVM30 is for most heat stable vaccines like tetanus toxoid, hepatitis B and pentavalent vaccines. When we look at multi-dimensional poverty index, which lies between 0 to 1 complementary to HDI, it is actually deprivation of 10 sub-indicators of 3 indicators: health, education, standard of living. Health includes nutrition and child health. Education, years of schooling and school attendance. And living standards include 6. These are fuel, electricity, assets, toilet, housing and water. Housing actually is represented by floor. So 3 indicators and 10 sub-indicators. But Niti Aayog has made it 12 sub-indicators by adding maternal health and bank account. Deprivation in more than 1/3 of these sub-indicators call it as poverty. Natural history of disease is progression of disease without any intervention. So if you look, the point C is the point where clinical symptoms and signs will appear, and it will mark the onset of clinical stage. Now, when we look at types of screening, you must know annual health checkup is applied on large number of population where we use more than one test to detect more than one diseases. So we are talking of multiphasic screening. But if you are looking at HIV in commercial sex worker, high risk or selective. Also, if you try to find out disease in family members and relatives of genetic disorders, that is also highly selective. But opportunistic screening is something like rheumatic fever, rheumatoid heart disease in school children, 5 to 15 years. Now, Kaplan-Meier survival analysis curve. We can compare in this particular example that definitely treatment B is leading to higher survival, 50%, even after 48 months of diagnosis, whereas without treatment, only 10 to 15% survival is possible. Now, Kaplan-Meier curve, 95% confidence interval. We recommend which bands to be used. Those are Hall-Wellner bands. We can also use Nayer's equal precision bands, and to compare different survival curves, we can use log rank test. which is based on p-value. Demographic cycle, India is in stage 3, where birth rate, green line is declining, death rate, red line is declining, and total population is in late expanding stage, yellow line. Then after that, stage 4, where both birth rate become low like death rate, population will stabilize. And finally, stage 5, where total population will decline. Why it will decline? Because death rate may remain same, but birth rate can decline to any extent. And this movement of a country from first till fourth phase, high birth rate, high death rate to low birth rate, low death rate is known as demographic transition. Population pyramid, age-sex pyramid, which is a double histogram having females on the right side. This is a population pyramid, age-sex pyramid of developing countries like India. Why? Developing countries like India, they have upright triangle with broad base, narrow top, indicating high fertility, high young age dependency. It also has lesser height as compared to developed country because it is lesser life expectancy, and it is asymmetric also, lesser females, unfavorable sex ratio. When we look at RCS program of India, it has got 2 IUDs, copper T 380A, having a shelf life of 10 years. And now we have also introduced multi-load copper T 375, having a shelf life of 5 years in the program. So 2 of them are available now. Now, when we look at HEED-AS, this instrument is used for psychosocial interview or evaluation of young people, especially adolescents. Earlier it was known as HEED-AS, but now components include home, education, eating, that is the food habits, activities, drugs, alcohol, that is the substance use, sexual life, self-harm, suicide, safety, and social media usage. When we look at Poshan Abhiyan, that is National Nutrition Mission of India, it wants to make India malnutrition free by 2022. It has identified 4 disorders. Sula pneumonic, stunting has to be reduced by 2 percentage points every year prevalence wise. Undernutrition again reduced by 2%. Low birth weight again by 2%. Anemia reduced by 3%. That is Anemia Mukt Bharat. Health belief model has got 3 components. Let's look at that. We have perceived threats, we have evaluation of behavior, and we have the modifying factors. Now, in this health belief model, if we want to have action, the final output we desire, then central to all of them is the component of motivation. In trans-theoretical model of behavior change, first step is pre-contemplation. Person is not aware that his smoking is a problem. Then comes contemplative stage, in which he is now aware about the problem of smoking and the risk it can pose to his life and health. Preparation. Now a person is ready to change. and this readiness to change is within next 30 days. He may have attempted this in last 1 year but failed also. Then comes action. Action means he actually now quit smoking. There is a behavior change, but this is less than 6 months. Once it goes above 6 months, this is the maintenance phase. And finally, when do we have termination? This is when the person has no fear of relapse of the smoking again. Then we look at Langley's saturation index. It has got 5 components: hardness, total dissolved solid, alkalinity, pH, and temperature. Its normal values lie between minus 0.30 to plus 0.30. If it goes below minus 0.30, we call it as LS negative. It indicates now there could be corrosion of the pipes and the boiler systems or the other equipment which are used. But if it goes above 0.30, LSI becomes positive. It may lead to actually scaling of all the pipe supplies, systems, and the equipment involved. Then we look at Anopheles larva. Is rest parallel to water surface because it has got no siphon tube like our nose. So it rests parallel to water surface. Directly oxygen could be absorbed from water surface and the skin. In contrast, Culex larva has a siphon tube, so it rests at an angle to water surface. Aedes larva also has a smaller siphon tube. And when we look at Mansonia, it is attached to roots of the plants to derive oxygen. Now, this is the formula of standard deviation, most commonly used measure of dispersion. Why? From the given value, you are subtracting the mean value. So you are calculating deviation. To remove negative sign, you are doing squares of all the deviations. You can see square. After that, you take their sum, divide by sample size. So now you have taken mean of those squares of deviations, and then you apply a root of that. Root of mean of squares of deviation, RMSD, is popularly known as standard deviation. This is a box and whisker plot where data is represented in form of a quartile. So middle line is the quartile 2, this is quartile 1, this is quartile 3, having minimum, having maximum value. When you look at the first box and whisker plot, also known as candle chart, you can see it is bilaterally symmetrical bell shape. Normal distribution. Mean, median, mode are same. Look at second graph. Here, longer tail is going towards right side. So this is right or positive skew. Mean is greater than median is greater than mode. Look at third graph. Longer tail here is going towards left side. Left or negative skew. Mean is less than median, less than mode. Look at the fourth graph. This is symmetrical, but it also has outliers. Theories of disease causation says if you put profit ahead of health, that is Marxist theory of disease causation. Feminist theory is due to role of females enforced in society by males. Personal theory says disease occurred due to, yes, social constraints or limitation. Foucauldian theory says disease divides population or segregate them into groups, making them easier to control. Macnion theory of tuberculosis says whatever reduction has taken place in incidence and prevalence of TB is due to change in socio-environmental conditions. Screw feed technology is based on the principle of high temperature but non-burn dry thermal technology. So we mix waste with a neutralizing material, inertizing material like cement lime, put it in the rotating auger, and we give heat from below. It reduces weight by 20 to 25% and volume by 80 to 85%. Please remember, it is applicable for all forms of infectious waste and sharp waste. It should never be used for radiological, cytological, or pathological type of waste. When we look at disaster cycle, please remember response, rehabilitation, reconstitution. 3 R's constitute recovery phase, whereas risk reduction phase is constituted by mitigation, prevention of conversion of hazard or risk into disaster, how you are doing to minimize the damage, and preparedness before the next disaster strikes. When we look at this, is a life cycle depicting Nipah virus, where you can see consumption of fruits contaminated with bad secretions like date palm syrup. This is a category C bioterrorism agent also. When we look at National AIDS Control Program, HIV, different types of populations, then there are 3 types: high risk population, general population, and in between, how will it reach from high risk population to general population is by bridge population. So when we look at high risk population, this will include commercial sex worker, men having sex with men, that is homosexuals, injecting drug users, and trafficked females. General population, this will include women, children, youth, and men. So who is going to act as a bridge between them from high risk to general is clients of sex workers, partners of IUD, migrant laborers, long distance truck drivers, and populations in conflict. So please remember, truck drivers are a part of bridge population group. When we look at Anemia Mukt Bharat, it has got 6 by 6 by 6 strategy, where we have 6 beneficiaries, 6 interventions, 6 institutional mechanism. We want to reduce prevalence of anemia by 3 percentage points every year from 2018 to 22. Iron folic acid supplementation in children below 5 years. This is 20 and 100 milligram and microgram respectively bi-weekly. Then we give weekly 45 400 to children 5 to 9 years. Adolescent gets 6500. Non-pregnant, non-lactating reproductive female, pregnant lactating female also get 6500. Pregnant lactating get it once a day for 180 days each. This program is linked with deworming program where albendazole is used. National Deworming Day is on 10th of February, repetition on 10th of August. When we look at ICER, what is ICER full form? This is incremental cost effectiveness ratio. As the word is telling you, it is used in the technique management of cost effectiveness analysis. How do we calculate it? Difference in cost divided by difference in effectiveness. When we look at bioterrorism agents, please remember most dangerous is smallpox, most commonly used anthrax because it is most easy to use, and most lethal toxin is botulism. Nipah and hantavirus, these are new emerging category C, and food water safety threats are in category B. Biosafety levels, if you look, category 1, biosafety level 1 includes non-pathogenic. When we look at COVID-19, it is in biosafety level 2 also, 3 also, but a better answer is biosafety level 3 because we do viral culture and isolation. And dangerous pathogens like Ebola, Marburg, Lassa, Hendra, they go into biosafety level 4. Friends, I have to remind you that this is the make or break time. All the ranks are made in this period only. So what are you waiting for? You have put in so much effort. Just stay on course for next 24 hours. Just keep on focusing till the last minute of the exam. And I'm sure you are going to get a desired result. And like me, you will achieve what you wanted to achieve from your professional career. All the best.
Hey guys, these are my predictions for tomorrow's exam. First of all, Dressler syndrome is post-MA pericarditis, tend to present with fever, pleuritic chest pain, and pericardial effusion around 2 to 8 weeks after myocardial infarction, especially after STEMI. It's thought to be autoimmune in nature, and treatment is going to be with high-dose aspirin, and steroids are generally not required. HFpEF drugs are very, very important for INI. SGLT2 inhibitors, findrinone, and spironolactone can reduce heart failure hospitalizations due to HFpEF, but there is no single drug that can reduce mortality as of now. DK management includes IV fluids to be started first, especially isotonic solutions like NS or RL to correct the shock. Insulin can be given slightly later by around 1 hour, but do not forget to check the potassium levels before starting insulin. GBS is going to be treated with either IVIG or plasma exchange, but not both. But you have to know that steroids and any form of immunosuppression is not beneficial and in fact contraindicated in the treatment of GBS. But in CADP, you can use steroids and immunosuppression. And CSF, it's going to show albuminocytological dissociation. Pulse abnormalities are very, very important in INI. For example, pulses alternance, which works based on the principle of Frank-Starling law, signifies LV dysfunction and severe LV failure. Bispherians pulse is seen in patients with severe aortic regurgitation and HOCM. In HOCM, we're going to get the typical spike and dome pulse. And pulses pavus at tardus is a characteristic feature of severe aortic stenosis. And dicrotic pulse can be seen in patients with sepsis and those who are on IABP. That is intra-aortic balloon counterpulsation. Hyperkalemia management includes IV calcium gluconate as the first-line therapy to stabilize the cardiac membrane. Later, we can start with insulin plus dextrose or salbutamol nebulizations or IV soda bicarbonate, whatever you want to. But these measures are temporary only, and the ultimate treatment in refractory cases is going to be dialysis, that is renal replacement therapy. In stroke, the thrombolysis window period is around 4.5 hours, whereas endovascular therapy can be done up to 24 hours. The first 6 hours, you have to do CT and CT angiogram to think about large vessel occlusion. And after 6 hours, up to 24 hours, you have to do additionally CT perfusion imaging also. Sepsis initial management is going to be IV fluids. In case if shock persists, you're going to start with vasopressors like noradrenaline plus or minus vasopressin. Hydrocortisone can be given in cases of refractory shock. TB meningitis will be diagnosed with basal exudates and imaging, but you have to be aware of iris in case if the patient is having HIV and if ART started before antitubercular drugs. COPD diagnosis is based on post-bronchodilatory FN by FVC ratio, which is going to be less than 70%. And in some patients with COPD, you can notice pseudo restriction, especially if FV is low and if TLC is normal or high. Infected endocarditis, the updated Duke's criteria is very, very important. In case if you're dealing with a typical organism, minimum 2 blood culture positivity is required. In case if it's an atypical organism, 3 blood culture positivity is required at least. The only exception to the rule is Coxella burnetii, where just a single blood culture positivity is enough to make a diagnosis. Hepatitis B serology is a hot area in INI. So you are going to just use 3 markers, surface antigen, anti-HBC, and anti-HBS. In that, the isolated anti-HBC usually suggests either the patient is in window period or the patient would have had a very remote exposure. In window period, anti-HBC IgM would have been positive. In a very remote exposure, anti-HBC IgG would have been positive. In case if it's SAAD, patients are going to present with euvolemic hyponatremia, with low serum sodium and low serum osmolality. Along with that, you're going to have a high urine sodium with a high urine osmolality. Cardiac tamponade is going to present with severe breathlessness, tachycardia, and patients are going to have the characteristic Beck stride, that is hypotension, muffled heart sound, and jugular venous distension. In the JVP, you're going to see a prominent X descent, but a blunted Y descent. Whereas in constrictive pericarditis, you're going to have a prominent X and a prominent Y. The prominent Y is called as Friedreich's sign. In case of tumor lysis syndrome, the characteristic electrolyte abnormalities are going to be hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia. And treatment is going to be with IV fluids, and prevention also is going to be with IV fluids and allopurinol. But please do not alkalinize the urine. That is not recommended as of now. Whereas in HIV patients, ART should be started regardless of the CD4 count, no matter what. And always be aware of the iris component if the patient is having additional tuberculosis also. And do not forget the vasculitides like Behçet, henoch-Schönlein purpura, giant cell arteritis, vaginous granulomatosis, which are extremely high yielding topics when it comes to your INI exams. And this time I'm predicting the post-ROC after cardiac arrest, that is post-return of spontaneous circulation. Especially, I'm expecting about when to do like coronary angiogram, especially the patient is having ST elevation that persists after 5 to 10 minutes after ROC. You have to do coronary angiogram within 2 hours. It's a indication for immediate and emergent coronary angiogram because you have to rule out STEMI-related cardiac arrest. And they might ask questions from target temperature management also, where the patient's core body temperature will be maintained at 33 to 36 degrees Celsius for at least 24 hours post-ROC, which can improve the cerebral outcomes. And thank you very much for your patient listening and wishing you all the very best for tomorrow's exam.
Hello friends, Hope you're all doing well. And let me tell you, these are some of the topics that I expect to be asked in the upcoming INI-CET exam. So these are based on PYTs. INI has a lot of PYTs. So let me tell you what I feel are likely to be asked. Of course, you are going to expect something from breast cancer, and they have asked breast cancer TNM staging. So they can ask you again on T stage, or they can ask you treatment based on the T stage. So something like what is an early breast cancer, what is LABC, what is metastatic, and they can ask you about BCT, the components, that is white local excision, sentinel lymph node biopsy, and radiotherapy. So look out for this T stage, especially the T4, T4ABCD. And remember, fixity to pectoralis major does not affect the T stage. In thyroid and parathyroid, again, they do ask this. In the last INI, they asked about treatment of papillary thyroid cancer. They may ask you, give you a clinical scenario and ask you whether you will do hemithyroidectomy, total thyroidectomy, or nothing at all. And these are the indications for thyroidectomy. Easy indications: compressive symptoms, complications, osmosis, toxicity, malignancy. They are the main indications where you will opt for surgery. Benign diseases, asymptomatic patients, you can just wait and watch. Of course, complications of thyroid surgeries like recurrent laryngeal nerve injury, this was asked last to last exam. Where does it get injured? Berry's ligament or Beer's triangle. And last exam, they asked something on primary hyperparathyroidism. So maybe this time they'll ask you treatment. If it's an adenoma, then you will just do a minimally invasive parathyroidectomy. But if it's a multiglandular disease, you will do a total parathyroidectomy and you will reimplant some bits in your left or the non-dominant brachioradialis. So watch out for that. Trauma, of course, last two exams, they have asked you components of primary survey. So you should know whatever can be done in an unstable patient is going to be done in primary survey. Maybe this time they'll ask you secondary survey, the components of ample. So watch out for that. And clinical scenarios, patient had a head trauma, they'll give you an image, CT image maybe, and ask you what is the diagnosis or the next step. Or chest trauma, they'll give you a scenario and you will have to differentiate whether it's a tension pneumothorax or a cardiac tamponade or a hemothorax. Those kind of questions are popular INI-CET questions. This is something students always ignore in surgery, wounds and ulcers. You will 100% get one question from ulcer or gangrene. So it will either be an image of a diabetic foot ulcer or an ischemic ulcer or a venous ulcer, something based on that. Grades of pressure sore came in INI-CET as well as in NEET PG. So you must know the 4 grades. Look at what is visible. Don't look at what is lost. So if I can see the subcutaneous fat, it is a grade 3. If I can see the muscle or the bone, it is a grade 4. Think like that. And of course, I am quite looking forward to something being asked on negative pressure wound therapy. This is something that is used for non-healing wounds, bad, dirty, infected diabetic foot wounds, or like you see in this photo, laparostomy where the abdomen could not be closed, or a burst abdomen for dirty wounds. In clean wounds, either you close them, or you put a graft, or if need be, a flap. Coming to flaps in head and neck, you will again get one question. Usually, they will ask you something from salivary gland surgeries, complications of parotid. You should know the nerves injured, Fraze syndrome, or submandibular gland surgery. You should know what nerves are injured. Those 3 important nerves: lingual nerve, hypoglossal nerve, and marginal mandibular. Last time they asked TNM of oral malignancy, they had given a photo and asked you the T stage. I feel this is a likely repeat. Okay, these kind of questions do get repeated directly. Images of flaps in head and neck and breast. So this is the PMMC flap. At least you should know PMMC flap, DP flap, radial free forearm flap, those kind of flaps, and tram flap and DIAP. These 4-5 flaps images you should know. GIT, of course, 3-4 questions will come. Recently, they have been asking on complications of gastric surgeries. Last time they asked during splenectomy, what vessel will get injured connected to the stomach. That was short gastric. They can ask you nutritional complications after gastrectomy, like iron deficiency or B12 deficiency, or dumping, which was asked a few years ago. Risk factors for colorectal cancer, drugs which may reduce the risk, like aspirin, metformin, I feel is important. And of course, the colonic polyps. Imaging and intestinal obstruction, this is surgery, radiology combined. So a particular disease, they will ask you the image like a coffee bean of sigmoid volvulus or intussusception or meconium ileus. And hernia, very popular INI-CET topic. I feel this time they will either ask you on something on the mesh, like the different places where mesh can be placed, or they'll give you an image like this. This is an IPOM mesh. Remember, you can see the intraperitoneal contents. It's an IPOM mesh. This device is a tacking device or a tacker. And the mesh used in IPOM is a dual mesh. It's a the lower side should be non-adhering. It is made of collagen. The upper side can be polypropylene. Okay, so watch out for that. HPB questions can be very straightforward or they can be very tough. So if it's very tough, don't break your head over it. Like last time they asked Hanover classification or bile duct injury. Those kind of questions you cannot handle, but normal questions, liver abscess asked last year should come back, either liver abscess or hydrated cyst. Every time they're asking acute pancreatitis, maybe now they'll ask chronic pancreatitis surgeries. At least you should know Fraze procedure, Eustace procedure, and one question from HPV tumors. Last time they asked CA gallbladder, maybe this time it will be pancreatic tumors. Urinary TB, one of the favorite topics for INI-CET. So they can ask you diagnosis, sterile pyuria, putty kidney, or a cystoscopic image of Gulf hole ureter. Imaging in urology, which is also going to be covered in radiology. So one image radiology in urology is going to be asked. It's quite commonly asked. This time I feel they will ask you something from testes, especially benign testicular disease in children, like cryptorchidism or testicular torsion or varicocele. And recent advances, last two exams, lot of laparoscopy related things have been asked. Maybe varies would be something easy. Staplers like this, circular stapler, easy to identify. Trocars, optical trocar, metal trocar, you know. Maybe if they want to put a googly, instead of asking you a normal open surgery instrument, they may ask you a laparoscopic instrument. Just one instrument you should know. This is a laparoscopy instrument. It looks like a hemostat in open surgery. You know, this is how hemostats are. They have serrations, they have a curved tip. This hemostat-like instrument, it's actually a dissecting forceps. It's called Maryland. Okay, Maryland forceps used in laparoscopic surgeries for dissection. So few these kind of things you can very well expect. Remember, INI-CET focuses a lot on PYTs. Some questions will be outrageous, don't worry about them, but the easy questions you must get right. Hope you found this useful, guys. Keep studying hard.
Hi, everybody. So now we'll be just discussing the few important scenarios which are possible asks in the INI November 25 exam. Remember, preeclampsia, eclampsia is a very important topic. You should expect one question from here. Remember, in preeclampsia, the important questions that are asked nowadays are prediction and prevention of preeclampsia. Preeclampsia can be prevented by starting low dose aspirin in women who are at high risk. We start the aspirin preferably before 16 weeks, and we give it till 36 weeks of pregnancy. How do we know the woman is at risk of preeclampsia? There are several ways. There's based on history, based on history, and specifically for history, we have something called the Gestosis score. If the score is more than 3, she's at risk of developing preeclampsia. Also, if you do a uterine artery pulsatility index more than 1, this is done between 11 to 14 weeks, she's again at risk of developing preeclampsia. Then there are certain biochemical markers. What the ones you should remember are the placental growth factor and PAP-A. These are reduced in a woman who might develop preeclampsia. And S-ENG, soluble endoglin, and soluble FLT1. These are increased in a woman who might develop preeclampsia. So that's important. So prediction, prevention is a very important topic. Eclampsia, so what you should know is that eclampsia is, number one, it's an emergency condition. It requires immediate delivery. It requires a very important drug called magnesium sulfate. This is something which you should know. Magnesium sulfate is not only useful in prevention of eclampsia, so it's for both treatment of eclampsia and also prevention of eclampsia. Apart from this, it is also used as a tocolytic. It is also neuroprotective, that is, protects the fetal brain in women who are at risk of developing, women at risk of preterm labor. And also, very importantly, It also reduces the risk of abruption in women who are hypertensive. So these are the other uses of magnesium sulfate. So preeclampsia, eclampsia, very important topic. Second important topic is Down syndrome screening. Now Down syndrome screening is done in two phases. It can be done in the first trimester. First trimester screening is done at 11 to 14 weeks, and we can either do a nuchal translucency on ultrasound, an NT more than 3 millimeter, we have to do a diagnostic test, or we can get a dual marker done, which has two tests, PAP-A and beta HCG. PAP-A goes down, beta HCG goes up in those women who are at risk of having a baby with Down syndrome. And then if we combine both, if we do both the NT and the dual marker, it's called as the combined test, which is commonly done. Now, the second trimester, if the woman misses the first trimester screening, or you can combine first and second trimester screening to improve the detection rate. Here we can do two things: a triple marker, which is not done nowadays. We prefer to do a quadruple marker because it has a higher detection rate. What are these? So, a quadruple marker is alpha fetoprotein plus beta HCG plus unconjugated estriol plus inhibin A. This is the quadruple marker. The triple marker is just the first three. What happens to these values? So wherever there's a B, beta HCG is going to increase. Inhibin also has a B. This is going to increase. And alpha fetoprotein and unconjugated estriol reduce in women at risk of Down syndrome. Also remember, where do you find alpha fetoprotein going up? Alpha fetoprotein going up is seen in neural tube defects, especially open neural tube defects, which can be easily diagnosed on an ultrasound. Also remember, the best test is none of these. The best test in terms of detection rate, the highest detection rate, is actually a test called the NIPT or cell-free DNA, which has a detection rate of 99%. It can be done anytime after 10 weeks, but remember, it's still a screening test. All these tests are screening tests. They have to be confirmed by a diagnostic test, which could be an amniocentesis, a CVS, or a chordocentesis. Next important topic is AMTSL, active management of third stage of labor. Very, very important. The initial what the WHO initially described as AMTSL, which is followed by the government of India also, or the initial WHO, said a few things. It said, first, rule out the presence of a second baby. That means it should not be an undiagnosed twin pregnancy. Give oxytocin, it's the drug of choice, 10 units IV or IM should be given. Then you should do a controlled cord traction and uterine massage. These are the basic four components. But over the years, things have changed and the focus has become more different. So what in 2012 the WHO said you can do several other things. So AMTSL now consists of giving oxytocin as the drug of choice. It's also added delayed cord clamping. So the cord should be clamped after 1 to 3 minutes. It should not be an immediate cord clamping. You'll do an immediate cord clamping or an early cord clamping only if the baby is non-vigorous or needs resuscitation. Then controlled cord traction by a skilled birth attendant. So in place of uterine massage, we now use the word postpartum vigilance. That is improved vigilance, including checking if the uterus is contracted or not. And lastly, maintaining the cold chain of oxytocin, because oxytocin has to be maintained in the cold chain. So this is what the WHO said in 2012. Now in 2018, it came out with another document, okay, which said other than oxytocin, we know is the drug of choice. You can use several other drugs. You can use carbetocin, which is a heat stable analog of oxytocin, so it doesn't require cold chain storage. You can use misoprostol in case you don't have anyone who knows how to give an injection. You can give methergin or methyl ergometrin, or you can give synthometrin, which is a combination of oxytocin and methyl ergometrin. So it listed all these drugs for prevention of PPH. Now, very new update, which is important for this INI, is in October 2025, the WHO came out with the next guideline. And it said that these two are no longer recommended for prevention of PPH in AMTSL. The drugs which are recommended for prevention of PPH are oxytocin, carbetocin, and misoprostol. That's the recent most update. Similarly, management of PPH, it's a really vast topic, but what's important is again the 2025 guidelines which came out just last month. And this says a few things. Number one, it says the definition we need to change. We used to take this as earlier more than 500 ml blood loss. We now take it as more than 300 ml blood loss following a delivery, plus any hemodynamic instability. And this is in terms of either a raised pulse or a low falling blood pressure or a high shock index. Any of these with 300 ml of blood loss, you can take it as PPH and initiate. So this is called early detection. Don't wait for more blood loss. Or if their blood loss is more than 500 ml, so in the event of hemodynamic instability, we can take a lower cutoff. That is the new change. The second important change is that it says that we follow what is called the E-motive guideline, okay, for the initial or the primary or the initial bundle of care. That means the first 15 minutes, if a patient has PPH, what do you do? E stands for early detection. Okay, so this is early detection by the definition I just mentioned above. M is massage the uterus. Okay. O is give oxytocin or other oxytocics. And in management of PPH, you can even give other drugs like methergin, like prostaglandins. Okay, it's only for prevention where we can't give. T is tranexamic acid. It's an antifibrinolytic, should be given within 3 hours ideally of PPH. IV is IV fluids. The IV fluid of choice is crystalloids. And E, this E stands for two things. It stands for examination, that is ruling out genital trauma and tears and traumatic causes of PPH. And second is escalation. That means quickly escalate to the next step. If it's not stopped, bleeding doesn't stop, go put an intrauterine balloon tamponade, or do an external aortic compression, or use the non-pneumatic shock garment, shift to a higher center, initiate surgical management. All that is done. So this is the E motive. It's emphasized. It was actually introduced in 2023, but it's re-emphasized to be followed in the 2025 guidelines. Shoulder dystocia, what should you know? You should know the helper mnemonic, very important. This is the mnemonic. Help, H is called for help, E is given episiotomy, L is legs, that is the most important maneuver, the McRobert maneuver. P is suprapubic pressure. So these four constitute the first line management of shoulder dystocia. If it doesn't work, baby still sucks, shoulders are still stuck, then we enter the rotational maneuvers. And these are two, the Rubin and the wood screw maneuver. R is the next one, remove the posterior arm. Sometimes it's able to take that, you can take out the posterior arm or roll on all fours. That is the Gaskin maneuver. These are the second line. If these also fail, then you move on to the third line. Third line are Zavanelli, push the baby back, do a cesarean section. Cleidotomy, try and fracture the baby's clavicle. Okay, and another one is symphysiotomy, which is deliberate fracture of the patient's pubic symphysis. Another recent update in shoulder dystocia, there is a new maneuver called the reverse Lofset maneuver. So if you've not heard this, if you know Lofset maneuver is in breech, when the arms are like this nuchal arms. But reverse Lofset is for shoulder dystocia. So just remember, Lofset is for breech, the arms in breech. Reverse Lofset is for shoulder dystocia. Primary amenorrhea, you should know the definition. The definition is taken as 13 years in the absence of secondary sexual characters, 15 years in the presence, or no menarche even after 3 years of thelarche. Right? Thelarche is the first sign of puberty. What do we do here? When the question says secondary sexual characters are present, the next thing you need to look for is the presence or absence of uterus. If the uterus is present, look for obstruction like imperforate hymen. If the uterus is absent, think of Mullerian agenesis, which is 46XX, or androgen insensitivity syndrome, which is 46XY. If the secondary sexual characters are absent, however, then you're going to think of a problem in the HPO axis. Okay, that means either the problem is in the ovary or it's in the hypothalamic pituitary. If it's in the ovary, what will happen to the FSH? It's going to be high. If the problem is in the hypothalamic pituitary, the FSH is going to be low. So that's the basic premise of the entire chapter of primary. So the next important topic is PCOS. Remember, PCOS questions are very important. You'll usually get a question from here. Remember, the diagnosis is by Rotterdam criteria, which says 2 out of 3 have to be present. This includes hyperandrogenism, clinical or biochemical features.
Then a delayed period, which is taken as more than 35 days, although the new definition of menstrual cycle has changed to 24 to 38 days now. And also remember that polycystic morphology on ultrasound, which says more than 12 follicles in one or both ovary, but the new guidelines say more than 20 follicles in one or both ovaries. Now, also remember that if a question comes on PCOS, remember optimizing her BMI should be your first priority, and that is the first treatment option. So always look for the option which says optimizing BMI. Also remember, drug of choice for infertility, ovulation, induction, and PCOS is letrozole. Next question, next important scenario, postmenopausal bleeding. Remember, the most common cause is endometrial atrophy, but we have to rule out cancer. The most common cancer to cause postmenopausal bleeding is cervical cancer. So look at the cervix. If there is a mass, take a biopsy. If there's a growth, take a biopsy. But if the cervix looks normal, we now have to look at the endometrium. How do we look at that? We do a transvaginal scan and look at the endometrial thickness. The cutoff we take is 5 millimeter. Any endometrium more than 5 millimeter needs to be biopsied in the postmenopausal period. And how do we do this? The way of choice is a hysteroscopy guided biopsy. Cervical cancer, clinically staged. Remember, we have stage 1, which is confined to the cervix. We have 2A and 2B. 2A is in the upper vagina. 2B is it's gone till the parametrium, but not till the pelvic side walls. 3A is lower vagina. 3B is till the pelvic side walls with or without hydroureteronephrosis, and 3 is lymph node, and stage 4 is, of course, we know metastasis, local or distant A or B. Now all stages are amenable to chemoradiation. Chemotherapy is cisplatin plus radiation, but surgery is limited to only the very, very early stages. Till what stage can we do surgery? Till stage 2A1. A is also divided as A1 and A2. So till stage 2A1 can we do surgery. All other stages chemoradiation. Remember, the preferred method now for cervical cancer screening is HPV. If you have the facility, HPV is best. All guidelines mention this. Okay, but if you don't have HPV, then a pap smear or a liquid-based cytology. Pap smear is basically cytology. So either do a PAPS or a LBC is also good enough if you don't have it. There's something called a co-test. A co-test is taking both together, HPV plus LBC together. And in a low resource setting, we can do a visual inspection under acetic acid. So if you're taking a HPV, it's once every 5 years. If you're taking a PAP or LBC, it's once every 3 years. If you're doing a co-test, it's again once every 5 years. Okay, and low resource settings is a VIA. Now, these are all screening tests. Any abnormality here, what will you do? You have to do a colpo plus a biopsy, colposcopy and biopsy. Endometriosis, buzzwords, fixed retroverted uterus, nodularity in the POD, pain, infertility, all this is endometriosis. Investigation of choice is a laparoscopy, but imaging also helps. So gold standard laparoscopy, but ultrasound will show you a chocolate cyst. Okay, and MRI will also show you features of endometriosis. Treatment, remember, if pain is the primary symptom, we usually prefer medical treatment. But if infertility or she has a chocolate cyst, then you might prefer a laparoscopy. Okay, a new drug which has come into the market for endometriosis is elagolix. It's very good with pain when the symptoms are pain. So it's an oral GnRH antagonist, and it has less side effects than the GnRH agonists. Last topic, intrauterine device, especially the timing of insertion. The timing of insertion is very, very important. Remember, in relation to delivery, the best time is within 10 minutes of placental delivery. If you've missed that time, then after 10 minutes to 48 hours, you can still put in a copper T. It's called as early postpartum insertion. Or you call her, you can also put in a copper T intra-cesarean at the time of cesarean, or else you call her after 6 weeks. Never put in a copper T between 48 hours to 6 weeks. You can also do interval copper T insertion. Interval copper T insertion means irrespective of delivery, best time is post-menstrual. Okay, you can even put it menstrual. You can even put it premenstrual, but premenstrual, you have to be sure the patient is not pregnant, which is difficult to do. So the best time is post-menstrual and menstrual. Avoid a premenstrual insertion. Okay, you can even use it as an emergency contraceptive within 5 days of unprotected intercourse. You can put in a copper T. You can even put in a copper T post abortion, post first or second trimester abortion. So these are the important take home points. All the best for your exam and see you on the other side.
Hello everyone, my name is Dr. Anand. Let's learn something. So today's topic of choice, this picture, video-based question. This baby has a swelling over the forehead. Can we appreciate this swelling over the forehead? If I say this swelling is confined to the suture line, if this swelling is confined to the suture line, what do you call this? You know that confined to the suture line, that is a cephal hematoma case, and that could be because of forceps delivery or traumatic delivery. And one more question, if I talk about this umbilical cord. So umbilical cord has how many arteries, how many veins? It has 2 arteries and 1 veins. If the patient has 1 artery, 1 vein, what will you think of? The answer is renal agenesis. Now, very importantly, delayed cord clamping also we can appreciate here. What is delayed cord clamping? Is clamping the umbilical cord after 60 seconds. What is the benefit of delayed cord clamping? Number one, the chances of anemia and blood transfusions in the baby will be less. And the negative points are asymptomatic polycythemia and jaundice. And if I ask you one more question, what is the normal weight of a newborn baby? The normal weight of a newborn baby is 2.5 to 4 kg. One more thing also, this baby has this whitish sticky material. What is this whitish sticky material? This is known as Vernix caseosa. Should you clean Vernix caseosa? The answer is no, we usually don't clean Vernix caseosa. The next picture is this one, very importantly. What can you appreciate? Can we appreciate this snowman sign or figure of 8 appearance? Where do you see snowman sign or figure of 8 appearance? The answer is supracardiac TAPVC. In a case of supracardiac TAPVC, very importantly, you see figure of 8 appearance or nothing but snowman sign. Now, one more important point I can appreciate in this picture, this baby right now is having this picture. So what can we appreciate here? Number one, this baby has, can we appreciate this milestone known as peekaboo? Now, this milestone is known as peekaboo. When can a baby say play peekaboo or hide and seek game? The answer is 10 months. A baby can play peekaboo by 10 months. The next important point we have over here is this picture. Now, in this picture, we can appreciate the palmer and plantar grass. So this one, so number one, can we appreciate acrocyanosis in this baby? The peripheries of the baby is cold, known as acrocyanosis. And number one, once I touch the feet of the baby, very importantly, this is known as palmer grass. This is known as palmer grass. So very importantly, number one, I'll appreciate this is known as palmer grass, and the baby has acrocyanosis. The peripheries are, acro means periphery and cyanosis means bluish discoloration. Last picture, very importantly, you should know over here, this newborn baby has rashes. Now look at this picture. This newborn baby have rashes over the body, and these rashes, they are the maculopapular pustular rash without an erythematous base. Now, this is known as, very importantly, that is neonatal pustular melanosis. And if the baby had, maculopapular pustular rash with an erythematous base, then the answer would have been, that is erythema toxicum. Last but not the least, very importantly, one newborn baby was there who was having a milk discharge. Let me show you this picture properly. This baby has a milk discharge. What do you call this? This is known as galacturia. What is the management? The answer is reassurance is the management. It's because of the maternal estrogen the baby have this problem. So thank you so much. Please take care. All the very best. And remember, you have got this. Everything will make sense. All you have to do is trust the process. And most importantly, deep breaths, 5 deep breaths. Inhale, hold the breath in exhalation before starting the paper, and then give your best shot. So please take care and thank you.
Let us begin the discussion. This is for Dermatology INI exam 9th November 2025. So, dear students, this is going to be the first clinical case scenario from dermatology subject. Hello, my dear student, myself Dr. Madana Srinivas. So, 30-year-old man presents with flaccid bullae that easily rupture, leaving painful erosions. Oral mucosal involvement is present. What is the most expected DIF picture of this case? If you have diagnosed this as pemphigus vulgaris, yes, absolutely correct. Your diagnosis is pemphigus vulgaris, which is an intraepidermal blistering disorder. So in this, DI finding is going to show the deposition of the IgG and the C3 in the epidermis in a pattern which is described as fish net, or it is also described as chicken wire. Chicken wire pattern. This is the first question. Next is a young patient on anti-seizure medication, anti-epileptic medication,
now developing generalized peeling off of the skin, and there is mucosa which is involved, and pseudo-Nicolsky sign is positive. DIF is negative. What is most likely diagnosis? If you have thought of the diagnosis as it is TEN, toxic epidermal necrolysis, you are absolutely correct, because the area of involvement is more than 30% body surface area, and it is clearly mentioned that the skin is peeling off. Here it is pseudo-Nicolsky because the skin is peeling off, not because of acantholysis, which is seen in the intraepidermal blistering disorders, the pemphigus group of disorders, but here because it is due to the necrosis, so it is called as pseudo-Nicolsky. And DF is negative. Why? Because there are no antibodies as such in this disease. There is going to be necrosis because of which the peeling is happening. So DF will be negative. So TN is a diagnosis. If the involvement was less than 10% body surface area, then the diagnosis would have been Stevens-Johnson syndrome. And here you can see the mucosal involvement is very, very severe. Next question, 5-year-old. There is a depigmented skin on one side of the chin and the neck. Closer examination, hairs are white in color, that is leukotrichia is present. Patient is otherwise healthy. There are no other lesions over the body. What is the most probable diagnosis? By this time, if you have thought of the vitiligo as a diagnosis, you are half correct. Another half you should think of is one side is involved. So it is having dermatomal distribution. So it is a segmental variety of vitiligo. What is the importance of this? It is a stable vitiligo, and it is going to be the surgery which will be the treatment option, but not medical treatment which will be useful in this case. Next question, intensely itchy grouped vesicular rash is present. DIF of the perilitional skin would confirm the diagnosis of dermatitis herpetiformis. So what will be the DIF picture? So here you can see papillovesicular lesions which are present over the extensors, which is classical for dermatitis herpetiformis. So this immunofluorescence is going to show the IgA deposition in a granular fashion in the basement membrane zone and also in the papillary tips. If you remember, in the biopsy, we can see papillary tip micro abscesses, that is neutrophilic collection in the dermatitis herpetiformis disease. 3-year-old presents with eczematous dermatitis, that is exam may also mention oozy itchy lesions primarily on the flexural surfaces. During infancy, the involvement was slightly different. It was over the face and over the extensor. So if you remember, the atopic dermatitis is the only classical disease in dermatology which will have this differential distribution depending upon the age. During the infancy, because of the crawling, there is going to be damage of the barrier function of the skin over the extensors. So extensors will be affected, but later on there's going to be predominantly flexural area involvement. And here also it is mentioned that there is a family history of the bronchial asthma. There can be mention of allergic rhinitis or hay fever or bronchial asthma in the family or in the patient themselves. So the diagnosis is going to be atopic dermatitis. You can see the cheeks are having this eczematous dermatitis, changes, oozing is also there. And you can see here the popliteal fossa is having this skin which is very pigmented, it is very thick, and it is having increased skin markings. This is what is called as lichenification because of the chronic scratching or itching of the skin. So this is the next question. Woman reports non-scaly itchy rash on the wrist. Further inquiry reveals burning sensation in the mouth when eating spicy food. Very important clues being mentioned here. On examination, purple plain-topped papules or the flexures are noted. There is white lacy streaks on the buccal mucosa. Amalgam is also present, as you can see in this picture. Also here. So what is the diagnosis? It is a giveaway. We can say it is lichen planus. Very important condition, which is autoimmune condition in dermatology related to papilloscomus disorder. But this is a classic one which is not associated with the scaling. Okay, lichen planus, right? Sure. Here you can see this is the lacy pattern which you are able to see. This is what is called as Wickham's stripe. Some names are important related to lichen planus, right? So next condition, patient presents a well-demarcated red plaque which are topped by silvery scale. So this scale is very important description. Silvery scaling is present. Symmetrically distributed on the extensor surfaces. What is the most likely diagnosis? By this time, I hope all of you have diagnosed it. This is a patient of psoriasis, where you are going to see this silvery white scaly plaques present on the extensor surface, the lumbosacral area, elbows, and the knees, as you are able to see in this picture. Next question, Bihar. Whenever you see this kind of demographic representation, especially in dermatology related questions, be very careful. It could be leprosy or it could be the leishmaniasis. So these are the things which you have to keep in your mind, right? Okay, present multiple hypopigmented macules on the trunk and several nodules on the face. Past history of prolonged fever several years ago was present. This is a very, very important pointer which is pointing towards a specific diagnosis. We'll see what is the given in the rest of the question. There is no sensory loss or nerve thickening. SSS, slit skin smears revealing the presence of the LD bodies, Leishman Donovan bodies. What is the most likely diagnosis? By this time, I hope all of you have thought of the diagnosis as PKDL, post-Kala Azar dermal leishmaniasis. Yes, the important differential is lepromatous leprosy. So quickly, how can I differentiate between these two conditions? Very, very simple. Both are going to present with hypopigmented macules over the body and infiltrated nodules over the face, but the differences are going to be very important. In lepromatous leprosy, there's going to be nerve involvement, that is, nerve thickening will be present, whereas in the case of PKDL, there's going to be this very important history of prolonged fever, which is pointing towards the visceral leishmaniasis previously. And also in the slit skin smear, we can see the amastigotes on the gene sustain, which is mentioned as Leishmania Donovan bodies on the gene sustain. Whereas here they are going to see the lepromatous leprosy, acid fast bacilli, Mycobacterium leprae will be seen. Next question, patient with atopic dermatitis presents with a well-demarcated circular patch of non-scarring hair loss. Examination shows short broken hairs which are exclamation marks, okay, hairs. Additionally, you note the presence of fine pitting on the patient's fingernails. What is the most likely diagnosis? This is a giveaway diagnosis. If you have thought of the diagnosis as alopecia areata, you are absolutely correct. There, the nail finding which is mentioned, it is a pitting of the nail which is going to be superficial, regular, and fine type of pitting, as opposed to that of deep, irregular, coarse pitting which is seen in the patients of psoriasis. Exactly contrasting nail findings. And why is this atopic dermatitis mentioned? Because alopecia areata is an autoimmune disorder where there is going to be destruction of the anagen heads by the lymphocytes. There can be possible association with other autoimmune disorders, like for example, it could be atopic dermatitis, or the patients may also have the thyroid disorders, hypothyroidism, Hashimoto's thyroiditis. Okay, so that could be another association with autoimmune disorder. So just keep this in mind. And you can see here the patch of the hair is having this intact white hair. This is what is called as turning white overnight phenomenon, which is again classical for alopecia areata, right? Next question. So this is another diagnosis, which is TTM, trichotillomania, which is a close differential for alopecia areata. But how can I differentiate? Here the examiner will mention that the female who is having the obsessive compulsive disorder is presenting with a patch of hair loss, which is incomplete hair loss. And also it is a hair loss which is present on the dominant side, and there are hairs of varying length which are present in the incomplete patch of the hair loss. And if you do the biopsy, we can see the presence of the RBCs perifollicularly, which is very classical. Right. Next is this question, 30-year-old man with non-pruritic scaly rash on the palms of the hands and the soles of the feet, and also issue of patchy hair loss discovers moth-eaten alopecia. Very important clue. Examiner may give you this as an image or as a pointer in the clinical vignette. And there are also moist resolutions of perianal area. The patient recalls having a painless sore on the genitals several weeks back, which has since disappeared. Given these findings, what is the most likely diagnosis now, and which serological test should perform to confirm it? So remember, dear students, previously there is a painless sore which could be due to the treponema pallidum producing the primary syphilis, but now it is not, no more primary syphilis, that has disappeared. Now the treponema pallidum is present in the bloodstream, producing this systemic findings, which is in the form of the palms and soles, showing this palmoplantar syphilids. Palmoplantar syphilids, I will show you the picture itself. So here you can see this is a non-itchy, scaly rash which you can see in the patients of the syphilis. That is secondary syphilis, especially you have to remember. And here you can see the picture of a moth-eaten alopecia. How is it going to look like? And here you can see this is a picture which is showing the condyloma lata perianally. There are moist lesions. And in the mucosa, we can also see the snail track ulcers. So secondary syphilis is a diagnosis. What is the investigation which you are going to perform to confirm the diagnosis? Yes, we are going to perform the VDRL because this is a patient of secondary syphilis. Right? If it was primary syphilis, then the confirmatory test would have been a dark ground illumination. Be very careful while reading the options. Always make sure that you are reading the entire question. You are going to do great because you have done all the hard work which you need to do for cracking this exam. All that you need to do is now have the confidence in yourself and a chill mind. You should go into the examination hall. You are going to do great. All the very, very best. Thank you so much. Happy learning.
Now, hot topics, they can ask you about Sugama Dex. They can ask you about CPR. They love asking you about CPR. They can ask you about ERAS. What is ERAS? ERAS is enhanced recovery after surgery. Then what is and they can ask you about malignant hyperthermia because this year only there was a case of malignant hyperthermia where the patient died. Okay. What is ERAS? ERAS is nothing but enhanced recovery after surgery. Okay, in ERAS, there are a set of things that they say we should follow so that patient recovers much faster. What are the set of things? Preoperatively, you admit the patient, you counsel him, you optimize him, don't keep him fasting for too long. If patient is going to be taken for surgery at 8 o'clock in the morning, don't say, "Arey, kal raat 10 baje ke baad kuch khana mat." In the morning, give him a carbohydrate drink like appy juice. Okay. Intra-op, don't give too much fluid to the patient. Give small, short-acting anesthetic agent. Try to give pain relief with regional anesthesia. Don't use too much of opioids. Use venous thromboembolism prophylaxis. Just go through once all of these things. Normally जो OT में करते हैं वो सब ही है, ठीक है? Post operatively patient को मुंह से जल्दी खाना खिला दो. Don't wait with Ryle's tube. Okay? Give enough amount of fluids. Don't make sure patient does not get much of nausea, vomiting. Okay. Remove all the catheters. Patient okay, next day only remove his Foley's, remove any drain tubes. You don't want patient to be moving around with Foley's, drain tubes, all that. Start making patient walk early. Fast chalo, fast chalo. Surgery के अगले दिन ही उसको बोलो चलने को, ठीक है? So all these are ERAS guidelines. Just go through this once. If they ask you what is this, madam, you see in a syringe pump. You see propofol is being given. Just close your eyes and mark this. Just close your eyes. Say thank you, Janvi Mata. Thank you, Janvi Mata, कि ये आ गया. This is TCI pump or target controlled infusion pump. It is used for total intravenous anesthesia. Total intravenous anesthesia. And what we give total intravenous anesthesia with? Most of the times we give it with propofol or with remifentanil or dexamethasone. Just remember propofol, okay? Yeah, pizza party. मुझे party नहीं चाहिए. Just say thank you, Janvi Mata, loudly in the exam, okay? ऐसा एक pump आया with this showing infusing, and here you can see this something CPT, PPT, and here you see this propofol coming. Just mark it as target controlled infusion pump used for TIVA or total intravenous anesthesia. Okay? ऐसी photo अगर आ गई, one needle is going in, and there is a big oval structure like this, and below that big oval structure there is the round carotid artery. This is nothing but IJV cannulation. With ultrasound guided, you're putting IJV में central line. So IJV central venous cannulation. Again loudly say Jai Janvi Mata. Mark the answer. Okay? Okay. ऐसी कुछ photo आ गई. Person is lying down on his side. You have put an endoscope in his mouth, and over here you're seeing a ultrasound picture. So this is nothing but TEE, transesophageal echo. Through the esophagus with an ultrasound, you're seeing the echo picture of the heart. Again say Jai Janvi Mata and mark this as TEE, transesophageal echo. Okay? Yeah, okay. Now, I think I have some last few things. Remifentanil, remimazolam, these are newer drugs. They may ask you about this in the sense, ज़्यादा कुछ नहीं पूछेंगे. They will just ask you which is a ultra short acting new synthetic opioid which has come. Fentanyl का short acting भाई आया है, उसका नाम है remifentanil. ठीक है? मिडाजोलम का शॉर्ट एक्टिंग भाई आया, अल्ट्रा शॉर्ट एक्टिंग भाई, उसका नाम है रेमिमाजोलम। बस इतना याद रखो एग्जाम में। कितना फास्ट काम कर रहा है, क्या कर रहा है, कुछ नहीं। फेंटेनिल का शॉर्ट एक्टिंग भाई रेमीफेंटेनिल, मिडाजोलम का शॉर्ट एक्टिंग भाई रेमिमाजोलम। सुफेंटेनिल इज अ मोर पोटेंट sufentanil, alfentanil, these are more potent as compared to fentanyl, but ultra short acting part is remifentanil. Okay, yeah, okay. Now last, sorry, I just want to do these two questions with you all. How to solve ABG? Matlab you all get confused in the exam. Okay, pH of the patient is 7.25. Is he acidotic or alkalotic? He is on the ventilator. You have to change the ventilatory settings. He is acidotic, correct? His PaO2 is 84 mmHg. Normal PaO2 कितना होता है? 75 to 100. So this is normal. So his oxygenation is fine. His PaCO2 is 62. Normal PaCO2 is 35 to 45. So definitely he has a lot of carbon dioxide being retained in. He is acidotic because he has a lot of CO2. So this is respiratory acidosis. Okay. So ma'am, how do I change the ventilatory setting over here? Arey bhai, remove the CO2, wash out the CO2. So to wash out the CO2, I have to increase the respiratory rate. I have to wash out the CO2, increase respiratory rate, or you can even increase the tidal volume. If you increase the tidal volume, more CO2 will go out. Okay, but mostly we will try to increase the respiratory rate. That's the first thing we will do. Okay, hyperventilate the patient. Hyperventilate, CO2 wash out by hyperventilation. Okay. Now, I have given you here what is the normal PO2, normal SaO2, and normal PaCO2 for you all to read. Okay. Now, one more over here. Solve this. Patient's pH is 7.43, almost normal. Patient's PaO2 is 54. Normal, I said, is 75 to 100. PaCO2 35 to 45, so it is normal. His SaO2, normal SaO2 is between 95 to 100. Okay. So here you can see that his PaO2 is low. PaO2 is less. SaO2 is also less. That means he has less oxygenation. So patient is on the ventilator. How should I improve his oxygenation? So I can do 2-3 things. First thing is I increase the FiO2. If patient was getting say 60% FiO2, give him 100% FiO2. Okay. Second thing I can do is increase the tidal volume. He's getting 300 tidal volume, give him 400 tidal volume. Third thing I can do is I can increase the PEEP also. PEEP will also improve the oxygenation. So I can do all of these to improve the oxygenation. All these three things will improve the oxygenation of my patient. So these are the only two possible ventilator related questions that can come. How to wash out the CO2, how to improve the oxygenation. Got it? I hope that you guys had a lot of fun. I hope that whatever I've taught उसमें से ही आ जाए ताकि मैं recall में भी mark करूँ ठुप 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 all this I have taught. All the best. Keep calm. Trust yourself. You know more than you think you do. Okay. Thank you so much, guys. Bye bye.
Hi everybody, so welcome to the last revision of radiology. So I hope that you do well in the exam. Stay calm, don't get panicked by any of these images or this class. Just watch this passively and with the intent of learning, not with setting a trigger button that oh my god I don't know anything. That should not be the case. Just learn now. What if it comes and you know now, right? So that should be the attitude. Just stay calm and it's never the short-term knowledge or the last-minute thing that really helps, but it's the long-term knowledge. Everything that you've done over the last 6 months, 1 year, it all comes into play. So just remember that. Let's start looking at a few important images, that I want you to refresh from the recent years. So this is what is an image showing right side. So this is first of all a CECT. You can see kidney is white, bone is white. It's a CECT, and you can see on the right side the kidney is not there, but it's replaced by this thing. When I see this gray color, no, it is fluid. Now, is this a cyst? Not really. You can see how it has the morphology of the kidney. All of these are the calyces, and this is the huge pelvis. So when I see the pelvis, renal pelvis dilated out of proportion to the calyces, this is what is pelviureteric junction obstruction. Also remember that if it is polycystic kidney disease, it would be bilateral. Also remember, Bosniak classification is for complex cysts. This image is showing an MRCP. What you are seeing are heavily T2 weighted images. So you can see the spinal cord CSF and you can see the bile duct. That tells you that's an MRCP. There is no endoscope, no X-ray, so not ERCP. What you see is the bile duct. This is the gallbladder. These are the intrahepatic radicals, all of which are dilated. So this is fusiform dilatation of the CBD, choledochal cyst type 1. What you see here, always recognize fat density. So this is the density of fat, which is negative, right? So minus 10 to minus 100 Hounsfield unit represents fat. Minus 1000 represents air. There are only two things which appear black, which have a negative Hounsfield unit. The reference zero is distilled water, and you can see calcification. So any mass with fat and calcium, always remember a teratoma. Could be in the pelvis, could be in the mediastinum. So this is a mediastinal teratoma. EDH work you need to remember. So when you see that it has this sort of a morphology like a lens, right, like a banana, this is SDH. If you see a biconvex like an idli, this is EDH. So this right here on the left side is an SDH, and you can see it's not hyperdense. It is chronic SDH. If it is white, hyperdense compared to brain, it's acute. Let's look at two pituitary masses. This is what is the sphenoid sinus, and this is what is the normal pituitary. So here, this enhancing mass on contrast enhanced MRI is suprasellar. Suprasellar mass, enhancing mass, cystic mass. This is craniopharyngioma. So they will give you hints: child, optic asthma compression, cystic in nature. Machine oil is filled. It's not water, it's thick machine oil which is filling it, and there can be calcification. Then look at this. You can see how this is also involving the pituitary. So this is sellar plus suprasellar. So when it is only suprasellar with normal pituitary, consider craniopharyngioma. When it starts from sella and then grows up, this is what is a pituitary macroadenoma. Craniopharyngioma happens in children, young adults. Macroadenoma happens in adults commonly, right? Look at these two X-rays now. Whenever you see any side is opaque, try and look for the mediastinal shift, right? So in this case, you can see a contralateral shift, the mediastinum being pushed. So this is what is a hemothorax. History of trauma is given. The vitals are given. You will say this is hemothorax. If patient is stable or unstable, for hemothorax, the next step is ICD, right? Look at this. This is where you can see one air fluid level. This is lung abscess. Finally, this is what a digital subtraction angiography looks like. We puncture the femoral artery, take our catheters and go to the artery of interest. So they can ask you, what is the artery being shown here? What do you think? So look at this. Try and imagine. You can see the posterior auricular branches. You can see superficial temporal. You can see internal maxillary. You can see the lingual and facial artery. So this is what is the external carotid artery. So this is one artery you may not have seen before. So this is artery or DSA, which is ECA, right? So that's it from my end. I hope that you get many questions from these images only. But overall, I know you will do well and give a good exam. See you on the other side. All the best.
Hi friends, all the best for tomorrow. Let's just brush up few key points at the last minute. Number one, hip dislocations. They just love in INI-CET. Posterior is more common than anterior. Posterior will have shortening. Remember that. Posterior will have shortening. Anterior will have lengthening. Posterior will have flexion, adduction, intonation. Anterior will have flexion, abduction, externodation. That is one thing. Also remember, posterior dislocation will have sciatic nerve injury as a complication. Amongst the bone tumors, they just love osteochondroma. It grows away from the joint, large to feel, small on x-rays. And there is a cartilage thickness which is more than 2 centimeters, converting into chondrosarcoma. Giant cell tumor, they just love in INI-CET. Skeletal maturity, 20 to 40 female. Mononuclear cells are the malignant component. Remember, they have soap bubble appearance. They have eggshell crackling, right? And the mononuclear cells are the malignant one. This is what you should remember. This is the only tumor which can go till the joint, which can go till the cartilage. Ewing sarcoma, remember, second decade, more common than first decade, a diaphyseal tumor in the middle of a bone, right? Presence like osteomyelitis, onion peel appearance, multiple layer outside. Translocation 1122, MIG2, right? CD99 is a specific tumor. This is what you should remember. It is the most radiosensitive tumor known to mankind. This is what you must remember, right? Giant cell tumor, remember, treatment is extended curettage. Whereas Ewing's, in spite of being radiotherapy, radiosensitive, the treatment is surgery, right? Before and after the surgery, neoadjuvant chemotherapy followed by surgery, then the adjuvant chemotherapy. Scaphoid fracture. This came in the May INI-CET also. There is an injury, right? Tenderness in the anatomical snub box. What will you do? If I can see a fracture, I will apply a cast. If I can't see a fracture, I will apply a glass holding or a thumb spica cast. Ask the patient to come back in 10 to 14 days and repeat the X-ray. Not a CT or MRI immediately. This is what you should remember. All right, in scaphoid fractures, the fracture occurs at the waist of scaphoid in the proximal pole, can undergo avascular necrosis because of retrograde blood supply. C for compartment, C for cast, because there's a compromise in the microcirculation. If there's a compartment syndrome, the treatment is going to be fasciotomy. Remember, pulselessness is the last sign, and stretch pain not relieved on anything is diagnostic of compartment syndrome. When there's a doubt, do a fasciotomy, release till the deep fascia. Supracondylar fractures are extra-articular fractures treated by closure plus K-wire fixation. If they show you a displaced supracondylar, that's Gartland's type 3. Remember, supracondylar fracture undergoes malunion into gunstock or cubitus varus deformity, and order of nerve involvement is anterior median radial ulnar. Whereas lateral condyle humerus fractures are known for non-union causing cubitus valgus and slow onset or tardy ulnar nerve palsy. Remember that Coley's fracture, right, goes posteriorly of the distal radius causing dinner fork deformity, and Smith fracture is anterior displacement causing garden spade deformity. Remember, all these injuries, the nerve injuries which are there occurring with fractures without, the important test for ulnar nerve, median nerve and radial nerve, there is no test. Ulnar nerve, the test you should remember, that is the card test, the book test, the Froment sign, the Igawa test and Wartenberg sign. In median nerve, remember the ape thumb deformity, the pointing index, the benediction attitude, the Oshner class test or the pen test. Radial nerve, the most commonly damaged nerve, there is no test, but radial nerve causes a wrist drop for which you apply a coccus splint. The posterior tortious nerve, a branch of radial nerve, causes finger drop, damage at the head of radius. The ulnar nerve and the median nerve causes claw hands. And to correct ulnar nerve and median nerve claw hand, you have a knuckle bender splint, whereas for radial nerve wrist drop, you have a cock-up splint. Radial nerve palsy, wrist drop, cock-up splint. Median nerve, pointing index, ulnar nerve, Froment sign, claw hand, knuckle bender splint for both of them. Remember, when they talk about Perthes disease, they will talk about avascular necrosis of femoral epiphysis, painless condition. You have, right, fragmentation of epiphysis. MRI is investigation of choice for majority of the things in orthopedics, and there's decreased abduction plus internalization. DDH is at birth more common in females. Asymmetrical thigh folds. The tests are Orto, Lani, Hip, Koandal, Lana, or Bahar Low. Again, the same thing, MRI investigation of choice. Pavlik harness and Wazan splint are useful. Remember, they can give you a rheumatoid arthritis scenario, bilateral hand pain, morning stiffness in a young female. They can give you young male with low backache, sacroiliitis. Diagnostic is sacroiliitis with HLA-B27 positive, red eye or heel pain. That's ankylosing spondylitis. This is what I wanted to say. And the most important thing is all the very best. All the very best. Enter the hall with a feeling that you are going to come out back with flying colors. Have the trust, have the faith. कहते हैं ना, believe तो रखो. All the very best. Thank you very much.